في عالم مليء بالتحديات، يصبح التأهيل المتخصص بوابة للأمل والتغيير. في عالم مليء بالتحديات، يصبح التأهيل المتخصص بوابة للأمل والتغيير. في عالم مليء بالتحديات، يصبح التأهيل المتخصص بوابة للأمل والتغيير. في عالم مليء بالتحديات، يصبح التأهيل المتخصص بوابة للأمل والتغيير. في عالم مليء بالتحديات، يصبح التأهيل المتخصص بوابة للأمل والتغيير. في عالم مليء بالتحديات، يصبح التأهيل المتخصص بوابة للأمل والتغيير. في عالم مليء بالتحديات، يصبح التأهيل المتخصص بوابة للأمل والتغيير. في عالم مليء بالتحديات، يصبح التأهيل المتخصص بوابة للأمل والتغيير. في عالم مليء بالتحديات، يصبح التأهيل المتخصص بوابة للأمل والتغيير. في عالم مليء بالتحديات، يصبح التأهيل المتخصص بوابة للأمل والتغيير. في عالم مليء بالتحديات، يصبح التأهيل المتخصص بوابة للأمل والتغيير. في عالم مليء بالتحديات، يصبح التأهيل المتخصص بوابة للأمل والتغيير. في عالم مليء بالتحديات، يصبح التأهيل المتخصص بوابة للأمل والتغيير. في عالم مليء بالتحديات، يصبح التأهيل المتخصص بوابة للأمل والتغيير. في عالم مليء بالتحديات، يصبح التأهيل المتخصص بوابة للأمل والتغيير. في عالم مليء بالتحديات، يصبح التأهيل المتخصص بوابة للأمل والتغيير. في عالم مليء بالتحديات، يصبح التأهيل المتخصص بوابة للأمل والتغيير. في عالم مليء بالتحديات، يصبح التأهيل المتخصص بوابة للأمل والتغيير. في عالم مليء بالتحديات، يصبح التأهيل المتخصص بوابة للأمل والتغيير.
بسم الله الرحمن الرحيم والسلام عليكم ورحمة الله وبركاته. Good morning, ladies and gentlemen, and welcome to the second day of the scientific forum for the recovery and rehabilitation in person with limb amputation. For today's agenda, we will be performing 7 scientific sessions and 2 workshops. I would like to thank our audience for coming today and also our expertise. For now, we will begin with each of our speakers sharing their thoughts on the topic, and then we will dive into more interactive conversation with the audience. And for now, I would like to first to introduce our first speaker, who will be talking about the understanding of prevalence and impacts of amputation. She is a physical and amputee rehabilitation consultant. Please give a warm round of applause to our first speaker, Dr. Maha Benad Alum.
Assalamu alaikum. Good morning, everyone. Today I'll be starting off our lectures by talking about the prevalence and amputation rates both globally and here in Saudi. So this is just an overview of my presentation. We'll talk about the global rates, then we'll go into regional and national rates, and lastly I'll talk about the projections of trends in amputation. No conflicts, no disclosure. Okay, so let's begin. It is estimated that approximately 65% of individuals living with amputation worldwide, 1.5% of these people undergo amputation every year. 60% of these amputations are for lower limb and 40% making up the rest of upper limb. Another study have also estimated that the global prevalence of these lower limb amputation ranges between 3 to 68 per 100,000 population. Before we dive deeper into the statistics, I would just like to clarify that there's no comprehensive data globally to report these numbers. They're mainly based on administrative data collected by multiple countries, whether it be national registries, insurance, medical reports, or medical records, and so on. Many studies have been conducted, for example, systemic review or the global burden disease study. These also come into factor when we're talking about the specifics of studies. They range significantly based on location, whether it's the country or region or specific hospital. Sometimes they focus on etiology, sometimes on the site of amputation, for example, upper versus lower. So comparing these studies sometimes can be difficult, but we've tried to compare and give you the results today. Next slide. So I've divided them into non-traumatic and traumatic. I'll talk first about non-traumatic. We all know that the main cause of non-traumatic amputation being peripheral vascular and diabetes. worldwide. A recent systemic study have actually reported that more than 202 million population or individuals are affected by peripheral vascular disease worldwide, and unfortunately the rate is increasing. It's projected to increase over time. And unfortunately, with the increase of the disease, the increase of burden, disability, and complication, thus increase in amputation rates. Same thing goes with diabetes. An interesting study have found that diabetics are 10 times more at risk of having amputation compared to non-diabetic patients. An interesting study based in the US actually have found that amputation due to poor vascular health has accounted for more than 82% of amputation, which is significant. This is a very interesting study. It was collected by, or the data was collected from the Global Burden Disease Study. And, this is a systemic study for European countries. Mainly European, but you can also see Australia and New Zealand were included in the study. The data were extracted by administrative data, which includes regional rates and insurance reports. You can see from here that the major amputation differs greatly from country to country. For example, Hungary is the highest, and New Zealand is the lowest country with the reported major amputation. In this study, they focused mainly on lower limb and peripheral vascular disease etiology. But overall, you can see an incline or decrease between the countries, with the exception of Slovakia. It's increasing over time. And there are many reasons that attribute to these declines or inclines, being better support health system, funding, conflicts within the regions, and so on. This study also focused on the age. They found that patients who are 65-year-old and more are at approximately 5 times, they have 5 times the risk of amputation compared to patients with who are less than 65-year-olds. Other studies with the diabetic-related amputations have reported an increase overall. An interesting study has compared the rates between the US and Scandinavian countries, and that they've found that the rate of diabetic amputation is increasing in the US and decreasing in Scandinavian countries. A similar thing was found with peripheral vascular disease. The rates of amputation in the US was increasing, while compared to the European countries, it's either stable or decreasing. Going into the traumatic amputation, these results were taken from the Global Burden Disease Study. And it's very interesting. Many studies have actually based their data on the study. We can see overall an increase in incidence, prevalence, and disability in contrast to the decrease in age standard prevalence incidence. So going into the specifics, the global incidence of traumatic amputations has increased from 11 million to 13 million within the span of a couple of decades, showing an increase of 16%. While the global prevalence has increased from 370 million to 552 million, showing an increase by almost 50%, which is very significant, unfortunately. And thus, you would expect the disability rates to go as well, and they have, unfortunately, by 39% over the span of 2 to 3 decades. In that study, they've also commented on the sites, showing that the prevalence of finger amputation was the highest, and the unilateral lower limb amputation caused the greatest burden of disability. This highlights the etiology for the age groups for the same study. As you can see, the top causes were exposure to mechanical forces, and it was the highest cause from the age group below the age of 60. From the age of 60 onwards, you see an increased rise in falls, caused by falls. Other causes were road traffic accidents, unintentional injuries, or animal contact. Congenital deficiency. Unfortunately, congenital deficiency is also underreported, especially compared to acquired upper and lower amputations. But I was able to find some data on it, especially in the European and American countries, and Australia as well. We can see, roughly, it was between 3 to 7 per 10,000 births. But other countries have reported much higher rates, going up to 20, unfortunately. The rate of congenital is somewhat stable compared to acquired amputation. So there's no significant increase or decrease. And as you all know, upper limb deficiencies are more common than lower limb deficiencies. And amelia occurs at a much lower rate and with significantly higher rates with stillbirth. Now, going into the regional statistics, there was one study that compared the data from the same study of global, the GBD study in the countries of the Middle East and North Africa. Overall, they found that the rates generally decreased in males, and the female rate has increased. They also found that significant increase in lower limb amputation in areas with political conflict or war, which is expected. They also found a decrease in Iraq, Palestine, Sudan, and Lebanon, and Kuwait. With lower limb amputation. This study focused mainly on lower limb amputation, not upper limb. So we can see that the trend is influenced by conflict, instability, natural disaster, and chronic diseases. I think what this study mainly highlights is the burden of these issues and the importance of targeting public health, limb preservation, and techniques to tackle these issues. Going on to national rates. Unfortunately, there's no national registry in Saudi Arabia that I'm aware of, but there are some reports from MOH. Unfortunately, these reports were taken only from medical rehab facility. I think Dr. Faiz briefly touched on it yesterday. This was done in 2012, showing the regions. Riyadh is the least, and Mecca being the highest. They also discussed the etiology. Diabetes-related gangrene was the most common, followed by car accident. There has been an update in the etiology from the MOH in 2021, showed similar rates. Diabetes-related amputation were the #1 cause, roughly around 50%. Followed by road traffic accident that has decreased. It was roughly around 20% of the causes. So I've tried to look into other studies that were done for amputation, and I've summarized the result of 3 studies that compared the amputation rate within their hospital. So there are 3 studies spanning, the first study was taken from 1997 to 1990, the other study was from 2013 to 2018, and the third study was from 2010 to 2020. You can see that the male-female ratio has decreased over time, going from 6:1 to 3:1. The mean age also has increased over time, from 30 to 45. The age distribution has changed as well, but that can be influenced by the data that was taken from the hospital. The sites, the most common site, it was consistent throughout all 3 studies, transtibial being the highest one, followed by transfemoral from the first and third study, and partial hand amputation from the second study. For causes for amputation locally are relatively similar to other countries, but trauma, in contrast to developed countries, is the #1 cause with diabetes. We may have a higher rate of road traffic accidents, but it has decreased over time. Vascular diabetes are one of the leading causes of diabetes here, what we mentioned in the MOH study. Other causes like congenital infection, war injuries, gangrene, cancer, tumors, and so on. But they're relatively low compared to other causes. These regional distributions were taken from the 2 studies, not the MOH one. It is important to note that the 2 studies were mainly done in Riyadh. So the proportions are reflected within their study that showed the highest population were in Riyadh, about 50 to 60%. And they found that less representation in other regions. But again, the studies were taken from a hospital based in Riyadh. Causes of amputation from the 3 studies. Trauma being the leading cause in contrast to the MOH study. Vascular is the second cause, and then followed by congenital and other causes. The global projection. So we're at the final slides of my presentation. I wanted to focus on the future projection of amputation rates. So a study in the US has estimated that 2.3 people in the US are currently living with limb loss. And they have projected that they projected an increase of roughly 145% by 2060. These projections were based on the increased projection of diabetes and vascular causes by 30 to 60%. So overall, the prevalence is expected to rise, particularly in developing countries. Vascular and diabetes are still remain the leading cause in developed nations. In Saudi Arabia, I couldn't find a specific study that focused on the projection, but there was one study, first of its kind, to talk about the projection, but it focused on lower limb diabetic amputations. And they based their studies on the previous studies that we've talked about. It's the other slide. And they've noticed the incidence rate is 2.6 per 1,000 people are at risk of having amputation every year, and they predicted that 1,647 major amputations are carried out each year in Saudi Arabia. I think, but from the numbers that we saw, this rate is underreported, but also this is only for the diabetic-related causes. But even diabetic-related causes, I think it's still underreported, and I think this just highlights the need of having database here in Saudi to see the national rate and have an accurate database. Going back to the Saudi Arabian projection, it is expected that increase in diabetes and vascular amputation will increase over the years. It's projected from the MENA study that around 500,000 diabetic-related lower limb extremity amputation, the KSA, to increase over the next decade, with a shift towards non-traumatic causes. So key factors influencing the trend. Aging population is a significant factor, raising prevalence of diabetes and vascular and the burden of these diseases on the population. Improvement of trauma care and workplace safety would result in decrease in traumatic causes to shift to non-traumatic causes. Advancement in vascular intervention may reduce the major amputation. Importance of implementing limb preservation in all regions of Saudi is a huge factor in decreasing amputation worldwide. Other factors that contribute to these, that should be looked into while looking at the prevalence is socioeconomic factors and racial factors. In many studies, they've reported significant difference between the races, whether in the US, of course, US has the leading role in reporting the different races. But that just shows that goes to show that how important it is to know your population and the risk of amputation to these populations, so you can target these populations that are risk and decrease the lower amputation. Also, the socioeconomic status is a huge factor. Multiple studies have found that countries with lower socioeconomic status have had higher amputation rates compared to ones that are with better economic status. And I think with this, I've concluded my I'm going back, sorry. These are my references, and I think I just concluded my presentation. Thank you. Okay.
Thank you, Dr. Maha, for the incredible and insightful presentation. And now we will move on to our next presenter, who will be sharing with us about the surgical of amputation prevention, decision-making, operative tricks, and pitfalls. He is a vascular surgery consultant. Please join me in welcoming our presenter, Dr. Hussein El Jaad.
Ouch. It's already on. Thank you so much. Oh, thank you so much. Should I ask you to change, or there is a remote to change the slides? Okay, thank you. Okay, thank you so much. I really appreciate the kind invitation to be part of this huge conference. And I want to congratulate you guys and for the great organization. My presentation will be talking about surgical, actual, hands-on, dealing with the patients before amputation and during the amputation. Our journey with the patient does not end by amputating the leg. They tend to come back to us either to deal with that amputated leg again or the other limb as well. Okay. So my introduction is actually more or less take-home message as well. As a surgical measure, amputation is a very valuable option to our patients. It's used to control pain, disease process that affect the limb, such as malignancy, infection, or gangrene. It's actually, sometimes it's a treatment, though it seems catastrophic when we say it to the patient, but it's a treatment modality. Every care should be taken to assure that the amputation is done only when clinically indicated. It's a valuable tool, but should be used wisely. So when there is no other option, like patient has been there following up with vascular, we did multiple interventions, endovascular or open. Now patient in severe pain cannot resume his daily activity, and we don't have any further vascular option, then we amputate the leg. Or it is non-salvageable or not cost-effective. Patient is unstable, or the patient risk of revascularization is huge, will put his life on risk, so we take that limb out. Amputation should only be considered if the limb is non-viable or cannot be saved for a reason or another, like gangrenous, grossly ischemic, malignant, or infectious process, or non-functional. Sometimes patients, they do present to us, but they present late. So trying to save that leg, we might end up leaving a skin and bone, but they will not be functional and will expose them for more injuries and more trauma. So better to take it out and replace it with an functional prosthesis. So Here it comes the last take-home message or introduction. A well-planned and executed amputation can remove a painful, dysfunctional limb and allow rehabilitation with a prosthetic limb to functional, painless state. So, as Dr. Maha just mentioned and took that huge burden out of my presentation, infection, mostly secondary to diabetes, is the main cause. It's around 70 to 80%. Diabetes in general, either directly through infection or through peripheral vascular disease, is the main cause of amputation that we deal with it on a daily basis. Peripheral vascular disease, as I said, 70% of it is actually secondary to diabetes. The rest is secondary to smoking and hypertension. Again, am I going back? Sorry. Neurological disorders, peripheral neuropathy, rarely would indicate an amputation. These are all rare causes of amputation or indications of amputation. Lack of protective sensation. If we revascularize an already dead leg, we will end up with dysfunctional limb, doesn't feel or move, so it's better to amputate it. Pain when it's extensive and it's going deep, again, with superimposed infection, it's another indication to amputate the leg. Congenital deformities. AV malformation, when it's advanced, taking a huge part of the leg, causing high output cardiac failure. Sometimes a patient is young. Below-knee amputation, for example, will save his heart and will make him more functional, and at least will stop that problem once for good. And malignant tumor, when we cannot get negative margin after multiple surgeries, we take it out. So let's go back to prevention. Now that's the area where when we decide to amputate the leg. Now, why not we prevent that end result? How can we achieve that? Diabetes. 70% of amputations are secondary to diabetes. However, we don't have that strict control, glycemic control of the patient with diabetes, so we can be one step ahead of diabetes, one step ahead of the patient before we end up needing amputation. And the problem with diabetes, why I concentrate on this, diabetes directly affects the immune system, wound healing. Patient will end up with renal failure, which will complicate the procedure, will put the patient at higher risk for revascularization, for example, will make anything you do is more difficult, harmful, will make trying to save the leg is not cost effective, and will end up amputating the leg to save his life. Ensuring adequate blood supply. This is a very difficult part of dealing with patients that they end up with amputation. Revascularization is a valid option. We are suffering on daily basis that the patient will come with occlusion or stenosis at one arterial tree, and they will ask for revascularization. When it's not indicated, we should not do it. Because what I used to tell my patients, and I think, I don't know if you agree or you don't agree, I'll ask later. So the first surgical intervention, be it open or endovascular on any patient, I have just put the patient in a train where the last station is amputation, if he lives enough. So why should I join that train to start with? If I have to, I'll have to. But if I don't have, try to get into that train, because the last station is amputation. So ensuring adequate blood supply when it's indicated, local wound care, including infection control. The risk of amputation goes double once infection is there. So try to avoid, we treat infection as soon as possible, even debridement before that, extensive debridement. Pressure offloading, that's your rule where you refer the patient to physiotherapy and rehab, diabetic shoes, sometimes total contact cast, something to enhance the healing. Patient education. Patient education, we are very short on that term. We don't spend a lot of time explaining to the patient the importance of blood sugar control, exercise, lifestyle modification. All are very important contributing factors to avoid the amputation. In local wound care, I just want to highlight that tissue debridement is very crucial, and we try to do it as soon as possible before the infection ascends or get more higher, where the need for amputation will be major amputation instead of minor amputation. When the patient refuses toe amputation or transmetatarsal amputation, sometimes we end up doing above knee amputation if we just delay it 2 days. So controlling the infection, tissue debridement, or even amputation is very crucial. Inflammatory infection control, IV antibiotics, and for sure, local wound care, different material of dressing is very crucial. It's more or less a repetition of what we have said, or I have already explained it. So, successful management of any patient that presents with diabetic foot or with a wound in the lower limb means removal of all dysfunctional and devitalized tissue while trying to reconstruct a durable residual limb. Only at this point I would say that I have succeeded in controlling or managing that wound, be it from trauma, be it diabetic foot infection, or be it gangrene. Now we go to business, goals of amputation. Why am I amputating that part of his leg? And excuse me, I'll be concentrating mainly on lower limb, by the way. So, first aim is removal of all dysfunctional and devitalized tissue. Second is to, while preserving as much length as possible of the limb, to use it as a functional limb as well. And to avoid for sure, as we will see later and probably was explained before, that the longer the liver, the remaining or the residual limb is, the better the outcome and easier for the patient to move after, or the amputee to move again. So we'll try to preserve as long as possible limb. Important to be painless, so we don't solve the problem of pain at rest because of ischemia. We create phantom leg or neuroma, then we end up with another problem. And for sure, sometimes we just do it because we need to preserve his life. Necrotizing soft tissue infection, causing multi-organ failure. The only solution is just a quick amputation. So, again, we said preservation of function. And as you know, the longer we keep, the more joints we leave behind, the easier for the patient to be, or the amputee to be, functional and ambulatory. And for sure, early return of function, early prosthetic fitting when possible, keeping the patient in-house, serial debridement for a month or two, we will just end up with muscle wasting, weakness, sometimes contracture, and it will be more difficult for them to walk again. So it's just in this, we can see the difference between the energy requirement between bilateral below knee amputation versus one above knee amputation. The requirement is higher. It's around 50% in bilateral, while it's 41% in bilateral below knee amputation versus 60%, 65% of above knee amputation. Leaving a joint is a huge impact, and you will teach me better than I do about leaving the knee to be used. So, assessing a patient before taking that decision of amputation. First, we cannot really overemphasize the multidisciplinary approach. Vascular, general surgeon, anesthesia, sometimes intensive care unit, and more importantly is the patient if he is awake. And believe it or not, the last one is the most difficult part. You will see some patients that will appreciate it, will be thankful. They will be more concerned about their life and their loved person well-being in comparison to leaving the leg. And you will see different patients where they will agree to die without amputating a toe. And I think spending proper time explaining to the patient and his or her family the need for amputation, how crucial it is to save her life or to save her kidney. His life, it's very important, more important than the leg or more important than the toe. If they do appreciate that and they understand it, most of them, they will agree. So, though it's difficult, but it's again, manageable. Then, sometimes you cannot have all the luxury of talking to the other subspecialties or the other specialties, having a lot of time, patient in multi-organ failure, necrotic soft tissue infection, white count of 54, patient is toxic. You just need to take the patient to OR. Believe me, at that point, we will not even think what's the difference between below versus above. We'll just do above knee amputation because it's quicker, faster, less impact on the patient, where we really concentrate about saving his life or her life in comparison to leaving the leg to walk on. And if you have enough time, we cannot decide that the patient has non-salvageable limb, no rule of revascularization before doing proper X-ray, Doppler arterial study. Sometimes we need CT angio. And at the end, last thing before we decide that this leg is for amputation, is doing on-table angiogram. I don't want to talk a lot about vascular part, but maybe in the next presentation, where we say that to do a bypass, we have an inflow and outflow. So on-table angiogram, just to make sure, is there any hope to save the leg for another 6 months or a year? So we assess the leg itself, and this is especially for trauma patients. We do receive a lot of trauma patients. We did re-implant 1 or 2 legs, our limbs, upper limb and lower limb. We succeeded in putting one that was attached only by skin, patient left walking. But unfortunately, the other limb, the upper limb, we couldn't save it. It failed multiple times. We tried like 5 times. It continued to thrombose, most likely because of the injury was not sharp. Sharp versus penetrating versus blunt. Blunt is more difficult to deal with. Usually the artery gets dissected, and whatever you try to save it, still it thromboses again and again. So we lost it. We tried our best like 3 times. He was young, non-Saudi, but unfortunately at the end we ended up amputating the left arm. So different scoring systems. Most common is the mangled extremity severity score, where we depend on the type of injury, low versus high energy or through high energy. Patient is stable and stable, presence of shock, absence of shock. Other injuries is very important, and the age, below 30, above 30. And that patient was sharply 30, that we could save his leg. The soft tissue status. As we said, we have to remove all the devitalized infected tissue, even if that entitles doing above knee amputation or even disarticulation. This is one of the crucial factors. Suitability of prosthesis. And this is, sometimes we do spend time on that. Because when their infection reaches only the ankle, they want us to do like ankle disarticulation. They ask, why would you go for below-knee amputation or transtibial amputation? We say that this is better for mobility and prosthesis. Sometimes, for me, leaving only the calcaneum does not help the patient. And we will say that, we'll see later that the Achilles function will pull the whole remaining part to the posterior, and I have seen it. Patient represented after multiple times of actually ulcer that doesn't heal, and upon looking at it, I said, okay, looked like it's completely opposite. Upside down. He's walking on the dorsum of the foot. We admitted him, we did a below-knee amputation. Then he walked again without problems. He spent like 6 months, 7 months going back and forth trying to heal that wound, which will never heal. Mobility and function. Yani, it's really difficult when you get somebody who is bedridden, just struck like 6 months back, and they have forefoot gangrene, and you tell the family it's above-knee amputation. Said, why don't you do angioplasty? Said, okay, angioplasty will put the patient at risk, might make it worse, will have all the anesthesia and surgical complication, and the outcome, if that wound heals, patient will not walk again. And if the patient doesn't walk, the angioplasty will fail with time, will re-occlude, then we'll end up doing another procedure. I don't know, that I leave it to you. I would like to hear from you, your comments about the non-ambulatory people going for above-knee amputation. Our classical approach, anybody who is not walking, it's above-knee amputation versus to amputation. I don't do below-knee amputation. They all end up with knee flexion deformity, stump problems, stump ulcers, then we bring them back for above-knee amputation. And now I'll go deep into surgical part, dealing with each part of amputation. Skin. We have to be very careful when we're dealing with the skin, especially the part that we will leave it to use it for the wound to close. It has to be painless, pliable, non-adherent scar. We get very careful about drawing the skin incision, thinking about the wound when it heals and the prosthesis. I don't know if you have seen this or not frequently, where the scar exactly in the middle of where the prosthesis is directly on it. So we try to avoid this. We push it a bit anterior. When we do fish mouth for above knee, we put the posterior flap, we make it a bit longer. So the scar will be away from the maximum area of pressure on the prosthesis. We don't have to close it immediately, especially in young patients, trauma patients. We can just remove all the devitalized tissue. Try to think about it, either free flaps if we have the service, skin grafts, vac. Try to save as much as possible of the length of the limb for the future ambulation. Muscle. Once we remove the muscle, it's about the different techniques of closing it, leaving enough muscle for the prosthesis to rely on, 1. 2, between only closing the myofascial closure does not stabilize the muscle, does not help the patient. We just leave it where at the end we'll have redundant skin with muscle wasting. Myoplasty, where we close the muscle together. Again, it does not balance properly the anterior and posterior muscles, flexions versus extension. The best thing in the literature, though honestly speaking, it's never being done, is the myodesis, where we create holes in the bone and we fix the muscles, according to below knee or above knee. And I think we are so much behind in that. Needs collaboration, we need training, we need to do it properly. So it helps with the walking and ambulatory status of the patient and the function of the prosthesis. Most of the literature talks about myodisis, which I have never honestly seen in any amputation. Yeah, I wouldn't say I did it almost everywhere. I did it in National Guard Riyadh, Specialist Hospital Riyadh, Specialist King Fahd here, QCH where I work now. Even when I was doing my fellowship, still, nobody does it. Though the literature clearly says it's way better than leaving it only with the myoplasty. So this is something that I learned after I prepared for this presentation. For the nerves, avoiding painful neuromas, there are tricks while doing the amputation that we concentrate on it. We have to separate. And I would say that most of the others, especially non-vascular, I'm not promoting for myself, they just take it as block and they close everything together. Artery, nerve, and the vein. And this is why you might see a lot of neuromas and a lot of painful limbs. Actually, I have seen few people, when they see the bleeding, they just put a clamp. They don't dissect the nerve, artery, and the vein. So the best way is just to dissect the nerve away from the vessels, apply proper traction. We do tie high ligation or high tie on the nerve, then we cut it where we see it retract like 5-6 cm above. And in above and below knee, it's better to put a nerve block catheter. This is excellent for post-op pain, hugely. Minimizes the requirement for opioids and for post-op analgesia. And sometimes we do sclerosing agents like alcohol injection. So again, decreases the rate of neuromas development and painful limb syndrome. Bone. We need to minimize the sharp edges either by beveling or filling. We do use bone wax. Capping the intramedullary canal to minimize the bleeding if there is any bleeding. And that I'll go more in deep in the second presentation. And we need to minimize the periosteal stripping. Exposing more bone from the periosteum, it increases the rate of exostosis. Now I'll go quickly, trying I'm not going beyond my time, about each type of amputation. I'll go with the common amputations, not all of them for sure, and certain tricks in it where we do the proper one. So toe amputation and re-amputation are the most common lower limb amputations, and mostly due to ulcers. Patient presents with gangrene. We do angioplasty or the bypass, then we end up with a gangrenous toe. It's better to remove it. I don't like auto amputation in diabetic patients because rate of superimposed infection is very high, ending up with necrotizing soft tissue infection and need for more higher amputation. So I try to amputate it once I do revascularize, not before it. Before the revascularization, I try to debride just to control the infection till I remove the infection. Then I revascularize, do the final debridement. If the wound is not infected, I'll leave it as it is. I'll do my bypass or angioplasty. Then I remove the gangrenous toe. Believe it or not, I'm sure again you know this better than me, the removal of even the smallest little toe affects walking, by all means. It changes the transverse arch of the foot, it affects toe amputation. Great toe amputation, for example, it affects the late stance phase of gait and the push-off stage of walking, the big toe. Like, this is one of the things that I have changed as well, Dr. Amel. After I was preparing, usually I don't leave one toe. If I remove 1, 2, 3, if I end up doing the fourth, I remove the fifth as extra. Now I do leave even if there is only one, especially if it's the big toe. I do leave it now. The second toe amputation may predisposes the patient for hallux valgus, where the big toe or the first metatarsal goes laterally, sorry. And the difference between it, the toe amputation versus re-amputation, we do remove the head of metatarsal, sometimes up to the mid-metatarsal. Shouldn't be done through the amputation. We will leave an exposed joint space or cover that is non-vascular, will not heal. So either before it, or we will have to take the head of the metatarsal with us. If it's infected, of course, we don't close it immediately. We leave it for secondary intention. Or delayed primary. Once it's clean and we're happy about the blood supply, we do close it in the clinic. Transmetatarsal or partial foot amputation. Sometimes it's extensive infection, affects most or all of the forefoot. We do amputate it. I would say 90% we do leave it open, putting back, leaving it for skin graft at later stage. It affects again stance and gait. Forward propulsion will be affected. Plantar flexion contracture should be avoided. Unopposed function of Achilles tendon. So we leave as much as possible. And as I said, if we leave only very short part, it goes just behind and the patient will start walking on the dorsum of the foot. If the wound is well healed, the patient can have excellent function. With proper filling or prosthesis, the patient would be better, almost normal. So advantage versus disadvantage of the forefoot amputation. It preserves length, maintains arch and metatarsal cascade, avoids Achilles contracture. However, disadvantage may need further surgery in the future. This patient, the pressure will be, if they don't get the proper prosthesis, this will create a pressure area that is not supposed to expose to that amount of pressure. Will end up with different types of ulcers. Skin might open again. Our bypasses or angioplasty may fail with time, and we might require another procedure. Some of our patients will not accept that lock as well. And it will be when they walk or they attend any social event. If they don't have that cosmetic prosthesis, their shape, it's not easily to be accepted from themselves or their family. So below-knee is the most common amputation or major amputation that we do. We do like it big time, honestly, for two reasons. It eliminates all the problems with the leaving part of the foot, while needs minimal or acceptable amount of training, exercise, prosthesis for the patient to walk again. And the chance that the patient will walk again is way higher than above knee amputation. And we can do it without doing a lot of major vascular interventions. Even if the whole superficial femoral artery is thrombosed, or occluded with open profunda, the chance of healing below knee is about 70%. So this is why we say it the first below knee at all costs, except the patient's life for sure. Following above knee, below should be. Following above knee amputation, only 40% of the patients will achieve grade 3 to 5. Know that the activity graded bid-bound like 0, fully independent 5. So only 40% of the patients following above knee amputation will end up having grade 3 and 5 functional status, compared to 80% of below knee doubled. The nerves are dissected on tension, so they will retract, as I said earlier. The tibia should be beveled with 45-degree, and the fibula should be ideally approximately 1 to 2%. And you can see the difference between the conical, where some of the surgeons will make the fibula 5 cm above, 5 to 10 cm above the level of the tibia, while the other one, the cylindrical, which is the ideal one, which is 1 to 2 cm above the tibia. Tibia is 1 to 2 cm above skin with the posterior flap. So the anterior flap, skin, 1 to 2 cm tibia above it, and the fibula 1 to 2 cm above the tibia level. Advantage versus disadvantage. So the advantage will preserve the knee, which will make the walking way less energy required, almost near the normal level of function in patients when they are young, ambulatory, strong enough, they have almost functional. You have seen people are running with the below knee amputation prosthesis. As we know, that affects the likelihood of further amputation. So if the patient walks, it decreases the risk of amputating even the same leg higher or the other leg in the near future. The problem with it is the risk of knee flexion contracture and may cause distal fibula pain. We'll go to above knee amputation. The optimal length is like 7 to 10 cm proximal to superior border of the patella. We do it in different levels. In the next slide, maybe it's better to go there. We have like 3 types. We have the short, medium, and long stump above knee amputation. It depends on the extension of infection, depends on the blood supply and failure. Sometimes we do revise even above knee amputation. It depends on the surgeon's preference. So if we compare the long length stump versus medium and short, the best one is the long, the longer the better. The muscular balance is better, preserving the strength of the adductor muscle, which is very important. That's better to do the myodesis in it, where we drill the femur and we fix it. And the energy is way less. Between the medium, if we have to do it, the adductor will be affected. There will be increased risk of hip joint, increased flexion and abduction in it, where will make the walking more difficult on the patients, and the energy will be higher as well. Where the very short one, the adductor will be almost gone. The femur will be way higher in abduction position, and the chance of walking almost 20% or even less. I think that's the last one. So for that, I will conclude my first presentation. Thank you so much. نقعد طيب.
Thank you, Dr. Hussein, for sharing your valuable knowledge with us today. And I would like now to invite back our guests, Dr. Maha and Dr. Hussein, to the stage to start our panel of discussion. أول شيء السلام عليكم ورحمة الله وبركاته. حابة أعرف عن نفسي. اسمي أروى يوسف أحمد، أخصائية أطراف صناعية وأجهزة تعويضية في مركز الأمير سلطان التأهيل إيفاء في الدمام. اليوم راح أكون your moderator for the panel discussion. Thank you, both of you, for joining us today. And for the panel discussion, I will start to ask some questions for both of you. Then I will ask the audience to give their thoughts and ask some questions as well. First of all, I will start the first question with Dr. Hussein, if you don't mind. My question to you is that in your slide, you mentioned amputation for congenital condition. Can you explain and give an example for such a case on congenital conditions? Also, what is your thought about amputation for a patient with PFFD, proximal femoral focal deficiency?
So for the first question is that, like when we have amniotic ring, for example, some kids will present with so, and it's underdeveloped the wrist of the leg. Amniotic rings affects blood supply in the intrauterine life, where for example, if it's here in the middle of the leg, the rest of the leg will be underdeveloped, very small. They cannot walk on it at all. So it's better to amputate it and put a prosthesis. And the other example, when the patient has extensive AV malformation. Patient I have seen it, he was around 14 to 16, has been following with cardiology and with the others, trying to do multiple sessions of sclerotherapy of that AV malformation. It just gets bigger and bigger, involving the whole leg, till he ended up on what we call high output heart failure. Like it will inject more than it's supposed to, but still he is so much behind. Like cannot cope with his daily activity. He doesn't perform any sport, he doesn't walk a lot, he cannot attend the school, all because of shortness of breath, like old man with heart failure. So once we remove that part of the leg, patient goes back to his normal life, and we just send him for rehab and the prosthesis, then he actually walks perfectly and resumes his activity. The other one, doing it the other question, doing an amputation to treat any form of dystrophy or difficult tumor, it has to be the last resort. Again, same applies to AV malformation. We tried sclerotherapy, multiple sessions, it just gets worse. Again, with amputation, if we can achieve any acceptable solution while saving the leg, will be a better option. Actually, I'll get to another example. What I used when I introduce or talk about chronic limb ischemia to any of my fellow residents or specialists, we say that it's a palliative care. We end up amputating the leg 100% if the patient lives enough. It's a battle between us, the primary disease of the arteries, and the life of the patient. If he lives enough, doesn't die from other causes like heart and strokes, we will end up amputating that leg like 90% of the time.
Thank you very much.
No problem.
And now I would like to ask Dr. Maha for about in your presentation, you stated that the rate of lower limb amputation for male has decreased compared to female in Middle East and North Africa. What is the main reason for the increased number of female amputees?
I think it was the comparison between male and female. The study was from 1990 until 2019. After they reported the changes between the ratio male and female, they correlated it with the socioeconomical changes that happened in these countries, and that justified the difference in ratio between the two.
What is the reason for the female amputation?
The rates of the amputation in females have increased due to a vascular better awareness and better healthcare system. Also, the male ratio has decreased as well in comparison to female, so that also is another factor.
Thank you very much.
Thank you.
Now, I would like to ask anyone want to ask a question for? Please, can you give the mic to Dr. Amal?
Thank you, Dr. Maha, Dr. Hussein, for your great presentations. It was very informative. First question for you, Dr. Hussein. I like the slide you mentioned about the train. إنه أفضل نحن نختصر الوقت يعني بما معناتها. So I think it's very nice to consult us. We as a physiatrist, we do pre-amp consultation to give, to support your opinion. Actually, we always support the surgeon opinion in this situation especially. Also, it may give the patient, he will be more comfortable in taking his decision. This is a big decision. Maybe introducing rehab team, prosthesis earlier, support your opinion as well. So I really recommend pre-amputation consultation.
So 100% agree what you have mentioned, that the rehab service is crucial, cornerstone, pre and post. I believe that I would talk about it maybe in the second session a bit about the psychological impact of amputation and what they accept and they don't accept. Definitely preparing the muscle of the other limb immediately or at the same time. The upper limb strength is very important. Showing them the options and showing them the rate of people that they walk 100% will make our life way easier on convincing them. So, but unfortunately, here it comes the clue or the problem is that we don't have that strong rehab services in every single hospital. And some of them, I don't know if you agree or not, are overwhelmed with the other aspects, like example, post-amputation people. And the third problem, when you don't have time, patient unstable, patient are refusing, they don't come, they don't agree immediately. It's some of them like 10-20% are planned amputation, while the majority are sudden amputation where the people come sick, unstable, already in renal, acute on a chronic limb ischemia, or as I said, bedridden, comorbid. The chance that you will end up helping them walking is very low. That's great when you have well-established service in your center and a planned procedure as well.
Exactly. If it is mainly a planned procedure,
definitely.
We can do it as an outpatient consultation.
I couldn't agree more.
Yeah. Thank you.
Thank you very much. Any other questions from the audience? Please give the mic to...
Thank you so much, both Dr. Maha and Dr. Hussein, for the comprehensive presentations. I would start no question for Dr. Maha, just thank you for the comprehensive, extensive, discussion in terms of the prevalence locally and internationally. So thank you so much. For Dr. Hussein, I echo Dr. Amal concern about the necessity of a pre-amputation consultation, but again, I agree with you too in terms of, especially if it is most cases critical or even life-saving, not an elective surgery. So mostly it is difficult to perform that unless you have an urgent team who can do the pre-amputation consults. Now, but whenever feasible, it's always recommended. Now, the second part is the a question about, or like, a comment for the below knee amputations versus above knee in terms of the functional outcomes. When it comes, you have clarified the importance of having even the big toe, because it's very important, especially with the toe off stage, like contributing about 50% of that stage, which is an important function for the patients. But when it comes to the below knee amputation too, as opposed to above, even if the patient is not a candidate or have like a severe comorbidity, it's not only the ambulation is the target. We do have a patient, we do the assessment, we sometimes the even passive interventions, even prostheses to be provided, even below the knee, to help out the caregiver to ease the care for the patient. This is another one of the objectives that can be promoted for below knee amputations, with definitely appropriate transtibial, like, if it is like, salvageable or like viable to be resolved. And the same issue with regard to the seating, there have to be like an appropriate seating posture that eliminate the need of like going, unless it is a critical necessity, definitely. Thank you so much, both of you.
No, actually, I would like to thank you for the second comment, which is very crucial. I'm aware of the sitting problem, that with the below knee is better than above knee, but for you to highlight the importance of the caregiver, because actually we don't look at him most of the time, that having prosthesis to help the caregiver, maybe in the washroom while the patient stands while preparing a thing, it's very important. But I would just turn the question back to you. How much of them you get them actually without the flexion deformity? Like, we are being consulted today for somebody whose the leg is there. It's not amputated yet. But the flexion deformity, where actually his heel or her heel almost touching the intertrochanteric area on the left and the other leg. So kind of, we have seen so many of them coming back with a flexion deformity, pressure ulcer on the tibia. The tibia actually is outside. The bone is outside without any coverage. So do you think, or which I will consider big time, honestly, but do you think you got those people really coming to you for the prosthesis just to help them make the life of the caregiver easier?
Yeah, sure. So in terms of the early, if we saw the patient like an early stage, usually we overcome that complication. Even at a later stage, but before that, even transfer, not necessary to be by the caregiver. Sometimes the patient will have the capability to have like very limited mobility, which will change. Being able to go to the bathroom or to be transferred and using the appropriate like wheelchair to go to the toilet or do even very limited activities, it's life-changing for the patients. The other thing also in terms of the amputation, definitely if there's a barrier in terms of contracture, the other surgical like intervention, even like passive intervention, passive surgical, in terms of surgical release of the contracted tendon, that can be offered as an alternative option. If there is no vascular limitations or neurovascular issues with the distal stump. The other option can be the knee disarticulation, which is discouraged, unfortunately. However, it's one option of management that most surgeons avoid as an option.
The knee disarticulation, during my, I would say, I'm not that old, but my career since 2008 till now, for the last 14 years, I haven't seen it once being done. I don't know why, though it's described very well in the literature. I wasn't trained to do it, honestly, and I haven't seen it being done, not even by the orthopedic surgeon. And if somebody in the audience from orthopedic can correct me. Again, the same comment about the other amputation. I have seen it. I have done amputations in Canada, in Riyadh, National Guard Specialist, here as well. I even not suggested. So I'm surprised and shocked as much as you are. And this is something that's worth looking at. Why we don't do this more frequently or at all, honestly.
Thank you so much.
No problem.
معلش تعليقا على هالنقطة. I agree with Dr. Faiz. Knee disarticulation is the choice. I saw it صراحة in my fellowship in Canada. I saw many knee disarticulation. It helps the person in
by whom? By whom? Which specialty was doing this? Which specialty? You have seen it. Is it vascular general surgeon or it's orthopedic surgeon?
شفتها من orthopedic. Very few from vascular surgery.
Yeah, this is.
Yes.
I thought so. Okay.
But it was amazing for transfer. يعني even the knee disarticulation itself helped the patient in transfer بشكل جميل يعني.
It's at least as good as a long above knee.
Yes.
At least. So makes all the sense. Yeah.
Okay, thank you so much for the fruitful and informative discussion. And also I would like to thank all the audience for engaging with us. And for now, we will stop for a break, lunch, and prayer time. And we will resume at 12.
Yeah, last thing.
Last question for Mr.
Thank you very much for being here. Thank you, Dr. Maha. Thank you, Dr. Hussein. Really a pleasure to hear from you. And the thing is that I will add a point regarding the management of amputation also. Post-op is also a mayhem for us. As a prosthetist orthotist, sometimes the people get with a lot of fluctuation of the volume. So the hard dressing, the elastic bandage, the garment with the vascular surgeons, if they educate the patients to deal with his volume fluctuation after the surgery, it will be really a good point for us. So this is the only thing I would add, because this is my nightmare, with the changing the sockets every day. Thank you.
Pleasure. Thank you so much for your comment. I'm trying my best not to tell real, true stories of the actual cooperation on the when we go to daily practice. Because when you see the response from some of the physiotherapists and rehab about immediate call post-op, like post-op below knee amputation, we do but the knee straight or knee braced to avoid deflection, deformity. But when we call them, why you are calling us immediately post-op? They are surprised. Why you are calling us? And pre-op, when you call some of them, they don't really do what is supposed. They don't communicate. I do like communicating with people. Even when I get a consult, I do phone them and I tell them my assessment and my plan, if they agree and they don't agree. Some of our colleagues, when they see the patients, they just write few words and they leave. If you agree or you don't agree on their plan. It's not like effective communication that we need for the best care of the patient. Patient had a huge trauma, a life-changing procedure for him or her or the rest of the family, and we don't spend like 15 minutes talking about should we put a program for him, what's the best way of doing the rehab, is it now, later, here, or another institution. Believe it or not, the patient that we re-implanted his leg, the decision was from one of the members of the team that was in the OR was revision amputation. The distal the amputated part was distal tibia, like few cm above the ankle. I wasn't on call, but they called. Shall we give it a chance? Said, okay, let's go. What's the opinion of the other specialties? Then they say, one of the specialties, they said, no, it's revision below knee amputation. Patient is only 30 and is perfectly fine, stable in the ER, and it was sharp injury. Everything is there. The only question I asked, did he see the leg? The answer was no, he saw the pictures. Said, come on, you are taking a decision. to amputate a patient, changing his life for the rest of his life, without even spending 30 minutes assessing the patient, actually seeing by naked eye that you can reimplant this amputated part or not. So when you ask me, do you really believe that we are working in optimal situations or environment? We need to educate ourselves, one, and to educate our patients for better care.
Doctor, you remind me of a word that always should be said actually and should be embedded in the way we think and we treat patients. You treat patient, not the organ. So if really everyone in that rehab sector would see that you are a patient-centered kind of approach, then we will overcome all this kind of miscommunication and challenges that we face after the intervention and during the patient journey. We talked a lot about, Dr. Maha mentioned, and yesterday we talked a lot about the shortage of statistics and data. And we all know that data is power. Maybe we can come up with this symposium. One of the actually recommendations that we can come up with, how can we overcome this challenge with putting a committee that would that cross sectors, and we do collaborate with each others from different angles and different perspectives to overcome this challenge. Maybe we need to sit and talk and see with having all this rich specialists and all this rich gathered of people in this field, how can we overcome this challenge actually? So I'm welcome you again and happy to have you all in Prince Sultan Rehab Center conducting and hosting this symposium is one of a key change that we look for in this region. We have a national commitment to this place, للمنطقة الشرقية وللدمام. I want to move to Arabic if you allow me. حابة إنه بعض المتواجدين خصوصا المستفيدين والمراجعين إنهم يسمعوا بعض التوصيات أو بعض المناقشات بالعربي أيضا بناء على طلبهم. وأشكركم تاني على الإثراء والغنى اللي تقدم من أمس لليوم الحقيقة. يمكن الواحد قد ما يفرح بإيفنتات كتير بس ما في شيء يقارن فرحة الإنسان بنشر العلم وبزكاة العلم اللي ممكن تقدم من كل أحد فينا موجود في هذا القطاع. فكثير من الكلام اللي قلتوه نفسي تعيدوه لكن بالعربي، بس يمكن الرد على العناية بمرحلة ما بعد الطرف في ظل وجود أشخاص من المستفيدين في هذا الاريا. يعني يهمني إنه يسمعوا هذه الجزئية لو تكرمت دكتور. شكرا. إن شاء الله.
I'll try my Arabic anyway. بالنسبة إلى المرضى قبل البتر وبعد البتر، العلاج الطبيعي هو شيء أساسي ونؤمن به بشكل كامل جدا. تقوية العضلات قبل، سواء العضلات للطرف الآخر أو إلى الجزء العلوي من الجسم، مرة مهم، يساعد على استخدام الطرف الصناعي، يسهل الموضوع فيما بعد. أيضا يحضر المريض إلى أنه يتقبل واقع البتر عندما يعلم أن نسبة المشي تتجاوز أو الحركة بدون حاجة إلى دعم من أي أحد إضافي، بدون الاعتماد على أحد، يتجاوز 80% حتى لو كان البتر تحت الركبة. فهذا بيسهل عليه تقبل فكرة البتر وإنهاء مشكلة الجرح المزمن، إنهاء مشكلة نقص التروية. أيضا تدخل الزملاء في إعادة التأهيل وفي العلاج الطبيعي من البداية يمنع حدوث كثير من المضاعفات، منها ثبات مفصل الركبة وقلة حركته، ثباته في وضع الثني مدة طويلة، كل هذه الأشياء مهمة، وهذا اللي إن شاء الله بإذن الله نصير نعمل عليه في الفترة القادمة، أن يكونوا جزء دائما من اتخاذ القرار من الفريق قبل وبعد البتر بإذن الله.
Okay, we will take a last question from. Can you give the mic to the last?
عليكم.
هل من ناحية خبرتكم كأطباء في ال 14 years اللي تفضلتوا فيها، هل شفتوا له نتائج as a conservative treatment to save the limb في in parallel to الانجيو ولا كل ال surgical intervention before الامبيوتيشن؟ لو استخدمنا الهايبرباريك اوكسجين ثيرابي شفناه في كثير من المستشفيات، يعني عليه دراسات، وفي كثير منهم يعني لما انت تجي تقرا في دراسات يقول لك انه الالسر هذه ويل هيلد في المرضى هذول الدايابيتك. فايش رايكم يا دكتور؟
I had limited experience مع العلاج، لكن من خبرتي يعتمد على المرض اللي مع المريض، قد ايش الجرح متقدم او لا، وهل فيه امراض ثانيه مزمنه او لا. بعضهم اللي شفتهم راحوا له، بعضهم صدق استفادوا، لكن الاغلبيه كانت النتائج.
اتفق مع الدكتوره في اللي تفضلت بان يعني بناء على طلب الدكتور نتكلم بالعربي though it's again difficult. الهايبرباريك اكسجين في if it's يعني اذا ما حلينا باقي المشاكل cannot be replacement، لا يعني ما يكون بديل للاشياء الثانيه، ممكن يعجل، او لما يكون المريض ما عنده اي حل to revascularize، يعني مريض ما عنده target vessel failed angioplasty. طبعا الان في by the way which is something that I wouldn't touch, it's advanced vascular، حاجه يسموها arterial venous fistulizing، وهو نستخدم حتى لو الشريان مسدود من الركبه الى الاطراف الى الاصابع، نجي نشبك الشريان في الوريد ونتخلص من الصمامات اللي تمنع انعكاس تيار الدم، فيوصل والسكسس ريت ماله up to 70%. في حلول حقيقة، يعني أنا attended واحد من الconferences it was in Emirates about this. There was like live case of the surgeon doing the procedure. بعد ما خلص قام vascular surgeon زي كذي وقال سؤال does it worth it؟ يعني أنا if I leave calcaneum تمام مقابل below-knee amputation, distal below-knee amputation, which one you will pick for your patient؟ أنت نفسك اللي سألت حضرتك. below-knee. فبعض الأحيان when you debride a lot of wounds، يعني أنا من الناس اللي صعب علي أتقبل رغبة المريض أمانة، يعني I don't want to waste your time خصوصا مع البريك، بس أنا من الناس اللي مو بسهولة عندي أتقبل رغبة المريض بحفاظ على الجزء من هذا الرجل، لأن أنا طالع في المريض أولا functional status، رغبته أحاول أقنعه بالمنطق وفي الغالب يقتنعوا إنه I have attended it multiple times. يعني أنا لما أجي أسوي transmitted heart cell believe it or not أنا سويت angioplasty إلى مريض بعد to amputation the next day the wound is clean great، بعد أسبوع جاب gas gangrene I had to amputate the whole forefoot. When they get infected diabetic patients it's يعني مو بس game changer، it's crazy how important to close the wound as soon as possible. leaving him for a trial that success rate in it 30% or less، وبعدين يجيني بانفكشن وبدل ما كنت انا طالع في بلوني اروح في ابافني او يدخل في acute kidney injury، it's huge to me. وارجع اقول في نقطه انا قلتها يمكن على السريع بس it's very important انا بالنسبه لي، لما يظل المريض 6 شهور رايح جاي المستشفى وعلى ويل تشير، وش بظل من العضلات حقه عشان البروستيسز ليتر، فالاوتكم على اللونج تيرم على الفاينل اوتكم is more important than leaving a toe or two or transmetatarsal wound to heal only. بالذات اذا مريض عندنا بعض المرضى بوست ترانسبلانت كدني ترانسبلانت. Exposing them to a lot of contrast, CT angio initially, then angioplasty after another. I wouldn't sacrifice that transplanted kidney and put him back on dialysis مقابل ان انا احافظ على الفورفوت. I would go for below-knee if I have to. Believe me, the decision of amputation is really difficult. I know it's away from the main question, which is the hyperbaric oxygen, which I don't go into it because time of essence. بالنسبة للdiabetic patients, it's very vital. If they end up with infected, the chance of major amputation is very high, changes the risk of amputation. Almost double to 10 times, from 2 to 10.
Okay, thank you very much for
بس
Dr.
الحجي
Hussein.
ما أنا آسف بس
But because we have to wrap up for the prayer time and lunch, apologies.
I think we have a little bit of time.
بس الحج هناك آخر شيء. على الويلشير.
Excuse me.
تفضل.
Yeah. I agree 100% with you regarding the bariatric, the hyperbaric oxygen therapy. We cannot wait. When you have a wound in a diabetic patient, it's really difficult to wait the effect of oxygen. I think we have to take a decision quickly, and when we take the decision quickly, we have better results. Regarding the conservative surgery, we face frequently patients come in with a forefoot completely deteriorated, but they don't like to go to the surgeon for amputation. We convince them, we explain functionally what is the problem. He will face always many difficulties, even to stand and to walk few steps. This is really important to convince.
يعطيكم العافية جميعا. وحاب أعطي نقطة مهمة from physiotherapy perspective على ضرورة pre-amputation consultation و guiding patient to access the surface. يعني تجيني حالات كثيرة بعد amputation يعني they don't know how to access the surface and they stay at home for 1 year or 6 months and they come with a lot of complications, contracture and edema, and they cannot يعني weaknesses because they don't know how to access the surface. So I need to emphasize on this point in pre-amputation consultation by any member of rehabilitation team.
Totally.
Last but not least, والله بقلبي ما ودي أخليها اللي هو البارشل فوت اللي احنا نتكلم عليها والمانجمنت حقها. ودائما قاعد نتكلم يعني هي من بودياتري، من بروستاتكس، من أورثوتكس، من بي تي، من او تي، من هيدروثيرابي، يعني كل شيء هذا سيركل معين. فانه وشو دائما احنا نطالع للديزيز، نطالع للاي سي دي 10. We don't see participation. Podiatry, he is the guy who will give the patient the product to get participated back in the active daily living. Thank you.
I'm afraid that we have to wrap up our discussion, and we will stop for prayer time and lunch break, and we will resume at 1 o'clock. 12:30. Thank you for. And for the workshop, it's on the level 1, the first floor, at 1 o'clock.
بوابة للأمل والتغيير. في عالم مليء بالتحديات يصبح التأهيل المتخصص بوابة للأمل والتغيير. في عالم مليء بالتحديات يصبح التأهيل المتخصص بوابة للأمل والتغيير. في عالم مليء بالتحديات يصبح التأهيل المتخصص بوابة للأمل والتغيير. في عالم مليء بالتحديات يصبح التأهيل المتخصص بوابة للأمل والتغيير. في عالم مليء بالتحديات يصبح التأهيل المتخصص بوابة للأمل والتغيير. في عالم مليء بالتحديات يصبح التأهيل المتخصص بوابة للأمل والتغيير. في عالم مليء بالتحديات، يصبح التأهيل المتخصص بوابة للأمل والتغيير. في عالم مليء بالتحديات، يصبح التأهيل المتخصص بوابة للأمل والتغيير. في عالم مليء بالتحديات، يصبح التأهيل المتخصص بوابة للأمل والتغيير. في عالم مليء بالتحديات، يصبح التأهيل المتخصص بوابة للأمل والتغيير. في عالم مليء بالتحديات، يصبح التأهيل المتخصص بوابة للأمل والتغيير. في عالم مليء بالتحديات، يصبح التأهيل المتخصص بوابة للأمل والتغيير. في عالم مليء بالتحديات يصبح التأهيل المتخصص بوابة للأمل والتغيير. في عالم مليء بالتحديات يصبح التأهيل المتخصص بوابة للأمل والتغيير. في عالم مليء بالتحديات يصبح التأهيل المتخصص بوابة للأمل والتغيير. في عالم مليء بالتحديات يصبح التأهيل المتخصص بوابة للأمل والتغيير. في عالم مليء بالتحديات يصبح التأهيل المتخصص بوابة للأمل والتغيير. في عالم مليء بالتحديات يصبح التأهيل المتخصص بوابة للأمل والتغيير. في عالم مليء بالتحديات يصبح التأهيل المتخصص بوابة للأمل والتغيير. في عالم مليء بالتحديات يصبح التأهيل المتخصص بوابة للأمل والتغيير. في عالم مليء بالتحديات يصبح التأهيل المتخصص بوابة للأمل والتغيير. في عالم مليء بالتحديات يصبح التأهيل المتخصص بوابة للأمل والتغيير. في عالم مليء بالتحديات يصبح التأهيل المتخصص بوابة للأمل والتغيير. في عالم مليء بالتحديات يصبح التأهيل المتخصص بوابة للأمل والتغيير. في عالم مليء بالتحديات يصبح التأهيل المتخصص بوابة للأمل والتغيير. في عالم مليء بالتحديات يصبح التأهيل المتخصص بوابة للأمل والتغيير. في عالم مليء بالتحديات يصبح التأهيل المتخصص بوابة للأمل والتغيير. في عالم مليء بالتحديات يصبح التأهيل المتخصص بوابة للأمل والتغيير. في عالم مليء بالتحديات يصبح التأهيل المتخصص بوابة للأمل والتغيير. في عالم مليء بالتحديات يصبح التأهيل المتخصص بوابة للأمل والتغيير. في عالم مليء بالتحديات يصبح التأهيل المتخصص بوابة للأمل والتغيير. في عالم مليء بالتحديات يصبح التأهيل المتخصص بوابة للأمل والتغيير. في عالم مليء بالتحديات يصبح التأهيل المتخصص بوابة للأمل والتغيير. في عالم مليء بالتحديات يصبح التأهيل المتخصص بوابة للأمل والتغيير. في عالم مليء بالتحديات يصبح التأهيل المتخصص بوابة للأمل والتغيير. في عالم مليء بالتحديات يصبح التأهيل المتخصص بوابة للأمل والتغيير. في عالم مليء بالتحديات، يصبح التأهيل المتخصص بوابة للأمل والتغيير. في عالم مليء بالتحديات، يصبح التأهيل المتخصص بوابة للأمل والتغيير. في عالم مليء بالتحديات، يصبح التأهيل المتخصص بوابة للأمل والتغيير. في عالم مليء بالتحديات، يصبح التأهيل المتخصص بوابة للأمل والتغيير. في عالم مليء بالتحديات، يصبح التأهيل المتخصص بوابة للأمل والتغيير. في عالم مليء بالتحديات، يصبح التأهيل المتخصص بوابة للأمل والتغيير. في عالم مليء بالتحديات يصبح التأهيل المتخصص بوابة للأمل والتغيير. في عالم مليء بالتحديات يصبح التأهيل المتخصص بوابة للأمل والتغيير. في عالم مليء بالتحديات يصبح التأهيل المتخصص بوابة للأمل والتغيير. في عالم مليء بالتحديات يصبح التأهيل المتخصص بوابة للأمل والتغيير. في عالم مليء بالتحديات يصبح التأهيل المتخصص بوابة للأمل والتغيير. في عالم مليء بالتحديات يصبح التأهيل المتخصص بوابة للأمل والتغيير. في عالم مليء بالتحديات يصبح التأهيل المتخصص بوابة للأمل والتغيير. في عالم مليء بالتحديات يصبح التأهيل المتخصص بوابة للأمل والتغيير. في عالم مليء بالتحديات يصبح التأهيل المتخصص بوابة للأمل والتغيير. في عالم مليء بالتحديات يصبح التأهيل المتخصص بوابة للأمل والتغيير. في عالم مليء بالتحديات يصبح التأهيل المتخصص بوابة للأمل والتغيير. في عالم مليء بالتحديات يصبح التأهيل المتخصص بوابة للأمل والتغيير. في عالم مليء بالتحديات يصبح التأهيل المتخصص بوابة للأمل والتغيير. في عالم مليء بالتحديات يصبح التأهيل المتخصص بوابة للأمل والتغيير. في عالم مليء بالتحديات يصبح التأهيل المتخصص بوابة للأمل والتغيير. في عالم مليء بالتحديات يصبح التأهيل المتخصص بوابة للأمل والتغيير. في عالم مليء بالتحديات يصبح التأهيل المتخصص بوابة للأمل والتغيير. في عالم مليء بالتحديات يصبح التأهيل المتخصص بوابة للأمل والتغيير. في عالم مليء بالتحديات يصبح التأهيل المتخصص بوابة للأمل والتغيير. في عالم مليء بالتحديات يصبح التأهيل المتخصص بوابة للأمل والتغيير. في عالم مليء بالتحديات يصبح التأهيل المتخصص بوابة للأمل والتغيير. في عالم مليء بالتحديات يصبح التأهيل المتخصص بوابة للأمل والتغيير. في عالم مليء بالتحديات يصبح التأهيل المتخصص بوابة للأمل والتغيير.
Wabarakatuh. Welcome back everyone, and I hope that you enjoyed your lunch break and recharge yourself for the next presenter. Now I would like to introduce our next speaker, who will talk about enhancing rehabilitation care for children with limb amputation and limb difference, addressing the underserved needs. He is a physical and amputee rehabilitation consultant. Please give a warm welcome to Dr. Faiz Al-Shahri.
Thank you. Assalamu alaikum. Good afternoon, everybody. Can I get the pointer? Yes. Thank you. يعطيك العافية. Okay, so today we are going to talk about both limb amputation and also limb difference, sometimes called congenital limb deficiency or limb deficiency. However, we'll use the term limb difference to address that issue. So we are going to talk about enhancing the rehabilitation care for those population. Before we start, the same disclosure like yesterday, none otherwise. Before we start, I would start by asking everybody just to raise your hand if you wish. Like, what do you think like is more common, the traumatic or the congenital amputations for people with limb amputation or limb difference in general in terms of numbers? Today you'll get like an introduction in the morning about the prevalence, more detailed emphasis with Dr. Maha. So what do you think? Let's talk, let's ask first for the traumatic causes. Okay, who do you think? Only one. What about the congenital cases? Is it more common? No preference? Okay, what about, yeah, one for congenital. Okay, so one and one. What about upper limb versus lower limb? What do you think is more common? The upper limb amputations, lower. Okay, so if we link it together, so upper limb and traumatic versus congenital, what do you think is the most common? Upper limb congenital, that's correct. And the lower limb is more traumatic. But overall, all in all, upper limb is more common. We'll go into some of the statistics in terms of a prevalence of both upper and lower limb amputations and also limb difference for those populations. So before I start, I will highlight the outlines that we are going to discuss today. Briefly, we'll talk about the prevalence of limb amputation and limb difference. And also we will highlight the importance of rehabilitation care for those population. And after that, we'll speak more in depth about the prosthetic interventions and also non-prosthetic, sometimes for some of the patients, but primarily the prosthetic interventions. Then we'll speak just briefly because there will be like a workshop detailing the outcome measures at almost 4 p.m. by Mr. Abdullah. But we will highlight out of the outcome measures that have been discussed, which one is more common or which one we use for or recommend for pediatric population. After that, we will highlight also some of the challenges that we do have, and I mean we have a lot of them. Some of the challenges that I addressed yesterday are applicable for those patients, but there are some considerations or challenges that is applicable for more applicable for children with limb difference or limb amputation. Then I will end the talk by suggesting some of recommendations that can be used as a guide or as a recommendation for this issue. Now, how prevalent? Let's start first with the international data for limb amputation first, and then we will address the congenital limb amputations. Again, I'm repeating some data that Dr. Maha have mentioned, but the average age for acquired amputations, mostly traumatic, at age of 6. This is the average, because most of them will have these like household injuries at that age. Mostly traumatic, mostly household injuries, and with the distal involvement as opposed to the proximal one. These for the acquired amputation, this is international data. Males are 3 times females. Like the first couple of years of life, as I mentioned, the household injuries are the most common cause or contributing factor for the limb amputation. For the older children, like aged above than 4, the other like injuries are more common. So the traumatic injury resulted from the like car accidents, the other motorcycle crashes and burns, etc. It's very important to highlight for the acquired amputations, specifically for the traumatic amputations. There is high risk in terms of morbidity and mortality because usually it's a severe injury. And fortunately, 70% of these injuries are preventable. Unfortunately, in terms of we can avoid it, and we didn't do that, but the good thing that we can work on that to improve the outcomes. Another, statistics we do have for those population is the amputation secondary to tumors. Usually it is in teenage years. However, like osteosarcoma is more with the younger population as opposed to those with Ewing sarcoma, which usually develop beyond the age of 10 years. Now, this is for the acquired amputations, the limb amputations. However, for the limb difference or congenital limb difference, defects, deficiency, the etiology is unknown mostly, and most of the cases is unknown in cause. And this is the estimate in terms of the general prevalence. It's like 5 to 10. Maybe Dr. Maha today, she highlighted that in terms of the prevalence. This is out of 10,000 live births. So for every 10,000, there is 5 to 10 births. The ratio, again, as I mentioned, in terms of international standards, international statistics, upper limb is by far more, 3 times the lower limb. Radial deficiency, 3 times the, in terms of longitudinal deficiency, radial is 3 times the ulnar. However, by far the transverse, isolated transverse deficiency is the most common cause of the amputation, and usually it's in non-dominant hand, as opposed to the traumatic, which is common on the dominant hand. Now, for the limb development, I'm not going to talk about the other, by the way, for the other lower limb deficiency, the longitudinal fibular deficiency is the most common for the lower limb. But you can see here the prevalence is very low as opposed to the upper limb deficiency. Limb development started the first, I would say from 4 weeks till 8 weeks of gestation, and there most of the limb development occur. And other causes, as we have mentioned in the beginning, we don't know about the exact cause. It's multifactorial, unknown. However, it's linked. There is some causes or other contributing factors, like having gestational diabetes, having other issues like smoking, maternal smoking, definitely maternal aged beyond 35, and some other factors like chorionic villus sampling. Okay, so local data. Again, we don't have clear data in terms of lower limb in the congenital limb deficiency, and the same for limb amputation. However, these are level 1 trauma center data from 2004 to 2018, and they found that trauma is the most contributing factor, which is no-brainer. It's a trauma center. And out of these trauma, usually with trauma cases, 30% they will develop, unfortunately, limb amputation. And mostly it was secondary to the all-terrain vehicle accidents. Majority aged first couple of years, as opposed to the international data, which is usually beyond 5. But the data was drawn from a trauma center. The other data, which is extracted from a tertiary center, rehabilitation center, collected the data of the patient from 2012 to 2020. For those patients, mostly they aged from 2 to 12, to 16,
And the congenital causes was, again, the most common. Again, it's a tertiary center. Trauma, or the acquired causes, trauma-related were 88%. This is the only, study I could found. It's a cohort study by Corday et al. They evaluated the occurrence of congenital limb deficiency in Saudi. So for the upper limb deficiency, it was 2 times more common than the lower limb deficiencies. However, but they included all other the congenital defects, birth defects, including cardiac, other system involvement. But this was reported for limb deficiency or limb difference. Again, these are the data that I have shared yesterday. We don't have data. Basically, this is another data from also our program for quarter 2 and 3. However, you can see similarity in terms of almost equivalent, the upper and lower limb involvement. However, this is calculated based on patients within the program, so it's not including all cases reviewed, new and follow-up cases. However, the complexity are variable. I'm not going to talk about the prevalence. I will focus now more on the importance of limb amputation for the impact we do have before the importance of rehabilitation. Again, rehabilitation is very important, and we'll talk thoroughly about some intervention, prosthetic and non-prosthetic. However, the impact of limb amputation is not only physical, as everybody think only the mobility part or whatever, the physical part of the disability. No, we do have the psychosocial impact, which is very important, and we'll pay attention for a couple of slides over that part. So, definitely the provision of appropriate medical care and excluding syndrome. So for physical impact for people or children with for congenital limb deficiency, usually, there is a certain percentage who will have another medical comorbidities that needs to be investigated. They would have other syndrome, but if it is part of syndrome, it has to be evaluated thoroughly, genetic workup. It depends on the cases, but the evaluation is very important. For the acquired amputations, on the other hand, there is a challenges, not only physical because of the nature of the amputation. There is also issue with regard to the wound healing, especially if we have seen that the acquired amputation mostly traumatic and secondary to crush injury or severe injury, which end up with difficulties in terms of wound healing. This is another physical problem. Bony overgrowth is a very important factor. It's a 40% prevalence in terms of specifically for children below age of 12. And this is understandable in terms of as they are growing at that age. And skeletal maturity is ongoing on that age. Humerus is the most involved bone in the upper limb, lower limb fibula. In terms of phantom pain, this is another problem, was highlighted yesterday by Dr. Muhammad. In terms of, but the consideration for management for pediatrics are different, and we lack the evidence, unfortunately, with that age group, unfortunately. For traumatic amputation, the phantom pain and phantom sensation is more common with traumatic causes and also the patient with cancer-related amputations. Lower limb is more common than upper limb, which is understandable in terms of the weight bearing and the intervention, the prosthetic intervention over that side. Okay, so prosthetic fitting and functional prognosis correlate with the mechanism of injury and definitely with the residual limb shape. Transverse amputation is always easier because we can treat it. This is applicable also for congenital limb difference. because it's easier to manage as opposed to those with the longitudinal or severe malformation or severe trauma cases. Again, the skin breakdown is another issue, as I mentioned, in terms of healing, and the issue of the skin breakdown. Even after the prosthetic intervention, there will be a risk for patients, and this is especially if there is a fitting problem, which Mr. Abdulsalam highlighted yesterday in terms of difficulties we face with fitting. The other factor also is the weight gain. So the weight fluctuation is a very important factor. That's why we educate the patient and the family to work on that, to optimize the prosthetic use, because with the changes in the weight, the stump shape and the socket will be inappropriate, or the fitting will be limited or affected. Now, we'll spend a couple of slides discussing the psychosocial part of limb amputation and also congenital limb amputation of difference. Okay, so in terms of psychological adjustment disability, it's a challenge. It is always a challenge for all, like adults and pediatrics. Pediatrics, the difference with pediatric patients or children, that the dimension of challenge is not only limited to them, it's also expanded to the family, especially the parents. So, I mean, the challenge is doubled. Now, it's very important to evaluate, screen those patients, and monitor any signs of common psychological issues or psychiatric conditions like depression, post-trauma stress disorders, and other associated issues or major conditions. In addition to that, the screening for self-image is very important, because now the self-image post-amputation is different. So there will be issues with low self-esteem, with a problem with bullying. And we will, actually in the next part, we will talk about some of the interventions, but self-esteem, it may vary or change throughout their life, but adolescent usually, the problem or the risk is associated with the internal factor of the aesthetic component, while those who are younger, the risk is usually from the external aspects of like aesthetic components, like bullying. So like as they grow up, the issues will be more internal, the secondary to low mood, anxiety, depression, so all internal, as opposed for those who are younger, because they will not think about, they are less prone to have these psychological problems. However, they will be prone for the bullying, for the external like stressors of having this limb amputation. Emotional support is essential for children with acquired limb amputation and also with those patients with limb difference. However, the impact is different, because those patients with congenital limb difference, they will grow up and they will be accustomed to their like limb difference. However, it's mostly impactful on those patients with acquired limb amputations, because it's a trauma. It's a major trauma for a child to lose a limb. So we have to treat it appropriately. The evidence here is not conclusive. However, there is like some suggestion below 6 years of age. It can be beneficial to use some dolls, a puppet, just to influence them to think more about the missing part. But it's not the only recommendation. Sometimes we use the opposite. We don't tend to influence that, especially with that age group, like below, from like 2-3 years of age. Sometimes we opt not to, just to neglect that issue, and as the patient grow up, we try to use more interventions appropriate for age and can also influence the child appropriately, and also protecting them, because sometimes the contact with peers also sometimes beneficial, sometimes it's unfortunately on the opposite side. So it depends, but the family support in this stage is very important. Psychological intervention, especially if you have a child psychiatrist and child psychologist, they play a major role with those patients. Also the child life therapy as well is very important. And all recreational like activities always helpful with that regard. But again, the evidence is not conclusive, unfortunately. The family acceptance for prosthetic device is very important, yes, because when we propose an intervention, if the family are not engaged, I told you, we have the patient and also their family as well for the younger population. So if the family are aware about the prosthetic intervention, they are in agreement on that plan, most likely this plan will be successful. And the other part also, which I addressed yesterday in terms of the limitation with the compliance. Sometimes the issues of the compliance is not probably from the patient or his or her willingness to attend for the sessions. Sometimes the parents, which is part of neglect, unfortunately, if they didn't attend for the therapy sessions, the follow-up, except if it's part of social limitations. That is another issue. It has to be addressed too. So these visits, frequent, regular follow-ups are very important in order to succeed in the intervention that you plan for the patient. If you cannot follow up the patient regularly, you make the appropriate intervention, you will definitely end up with difficult or unfortunate outcomes. The home setup is important, especially for those with bilateral upper or bilateral lower amputations, because sometimes this is crucial in terms of easing the functionality, which we'll discuss it later on, the non-prosthetic interventions. The child environment, leisure activities, community setup is important, as I mentioned, and to choose the appropriate procedures. Okay. What about the importance of rehabilitation care for children with limb amputation or limb difference? It's very important, as we highlighted yesterday, and the role of multidisciplinary or even interdisciplinary family-centered. What we will add to that care, it has to be family-centered. Family-centered for pediatrics or children with limb difference, limb deficiency. If you didn't include the family, whatever intervention, it's not going to be successful. So it's very recommended coordination between not only the rehabilitation team, the whole spectrum of healthcare participating in the care of those population, including surgical team, according to the surgical need. Medical also team is important, especially for the medical needs related to the case. But one very important factor, again, so the care, the only difference, or the major difference between the adult and pediatrics rehabilitation care, adults, we emphasize that pediatrics, they have the family-centered care, which is very important. The other thing also, those therapists who are working on with those patients, not only they need to be aware about the amputation rehabilitation, they do have to have a knowledge how to deal with the children. So their needs are different, important to be addressed. So these are very important and critical points if you think about the dimension of care for those population. again, we highlighted the importance of coordination of care between all discipline. And the role for physical therapists, definitely everybody knows in terms of assisting in mobility. And just in brief, but I mean, their dimension of care extend to beyond that. The same for occupational therapy involvement, specifically for limb amputation. We usually involve them for, it's not necessarily only lower limb, but for all activity of their living, but their role is higher with the upper limb involvement as well. A prosthetist, having a prosthetist with interest or with experience with pediatric population is important because their needs are different. They need to have frequent, as I've mentioned, follow-ups, and also their alignments will have like some specifications at certain ages as they grow up. The role of social worker and psychologist is very, very important, as I mentioned, to address the psychosocial problems that we highlighted before. Now, let's talk about prosthetic and non-prosthetic intervention. Let's start with the prosthetic interventions. So, how can we deliver the appropriate intervention? It has to be related or matching the development stages. So, otherwise, if you are not following the development of the child, you might have a goal that is not realistic for that age group, or you might go and think that you did the appropriate intervention, yet this is, a goal that is expected to be achieved like 1 or 2 years prior. So it has to be matched with the appropriate development stages. In terms of function independence, for the patient has to be trained on both, with the prosthesis and without the prosthesis. This is very important. The rejection of the prosthesis sometimes is accepted, specifically at certain amputation levels. And we, especially if it's not enhancing the function. So sometimes it's not recommended to push toward certain interventions that is not necessarily for a patient. Also in terms of anticipation, some prosthetic interventions or components, we might anticipate the growth of the child, so we might do some technical interventions just to match that rapid growth, specifically in the first 2 years of life. This is crucial, especially if it's difficult to arrange very close follow-ups. Yes, so usually if the child is not complying with using the prosthetics, not necessarily because sometimes there is the primary you have to fit is to check is the fitting problem, the prosthetic issue, the functionality. These are the most important causes. However, sometimes if it is or sometimes an appropriate choice. So sometimes you have to revise the choice that you have provided to the patient. Sometimes it could be as simple as that if we didn't match the appropriate intervention to the appropriate child. Okay, in terms of handedness also, the younger children, usually they have easier time to adapt for hand dominance, which usually by age of 2 will be more prominent. This is sometimes it's earlier. As a child age and develop new hobbies, we have to develop the other interventions that match these hobbies and some task-specific devices or a terminal device that match that needs. Yeah. So sometimes the family, they see that the patient or the child is rejecting this intervention. But if it is, sometimes they need to be counseled. If this is not matching the patient function, it is recommended to counsel them to understand that limitation and reassure them that that could be part of the limitation. So sometimes they would like to take out the device, especially if it's limiting function. Sometimes I recommend it, to be honest, in the first couple of years, if for certain intervention that's specific or not appropriate, and we withdraw that intervention if it is not functionally appropriate, especially for upper limbs. Yes, and it's very important to monitor the child rejection of the devices if the family are pushing. Sometimes they are pushing, so you have to counsel both of them and to make sure that the rejection or disapproval is appropriate. In terms of the follow-up, how frequent we need to see the patients. So this is a rough, recommendation. However, they need to be closely monitored. So for first 2 years, I would advise to be seen in every 3 months. But as a patient age, it can be spaced into 6 months interval, and then gradually into every 2 years, and then 5 years, and then that would be appropriate. So annually, and then 2 years, and then 5 years by the age of adolescent while transitioning. I mean, this is for the prosthetic prescription usually. It's not for follow-ups. Follow-ups has to be closer, and you will decide about the functional outcomes, the type of patient. So there is no clear rule in terms of follow-up. Again, components has to be age appropriate, addressing all the other factors. Comfort is very important, weight, durability. I've seen certain interventions using a weight inappropriate, for example, knee component that is not suitable for a pediatric age or adolescent age. And what will happen with the patient? He will reject the procedure because it's too heavy for him. And the problem can be solved just by using appropriate knee joint, which is appropriate for this pediatric age. The cosmesis is another important factor, especially if you are addressing the psychosocial components. And this is very important, especially for adolescent age. Non-prosthetic intervention is as important as prosthetic interventions, especially for those with major bilateral upper and lower amputations. Those patients, you have to look into the appropriate assistive device. So you can adopt certain walking aid modified to suit the patient needs with appropriate prosthetic intervention if feasible, and be realistic in terms of the functional use. You might do intervention for a single side, aiming to achieve certain functional outcomes. It's not necessary to be a prosthetic. Sometimes you need to adopt orthotic intervention with specific function after evaluation, and you will fabricate or design some intervention that's suitable for that function. The other thing also, it's very important to collaborate with the team in terms of deciding the appropriate intervention. And the other recommendation also for those patients, it's better to tackle one problem at a time. So now we will focus on eating, and then after that, because the child he or she needs to develop the skills for that new task that he's learning. So when you do that, do it at a certain point, and then after that you can move to another function that you would like to target, and then in a spaced manner. In order to, that's a previous skill he mastered it, he or she already mastered that intervention. So the second part will focus, for example, on the other aspect of either mobility, either whatever issue that you need to prioritize according to the most important need for the patient. But ultimately, many of those patients, they will opt for non-prosthetic interventions, but make sure that the appropriate function is selected and addressed appropriately. In terms of outcome measures, and there will be a session in the afternoon with Mr. Abdullah. However, for pediatrics, the same in terms of the evaluation of cognition and the family feedback. This is another outcome measure for pediatrics also. But in terms of the outcome measures that we use, we have a couple of them. These are some of the outcome measures that can be used for upper limbs, in addition to COMS. And for the lower limb, WFIM can be used as additional outcome measures. K-level can be used, but for older children. And it helps with prescribing certain functional components. However, the evidence with these interventions is still debatable. But these are the most studied outcome measures out of the outcome measures that we do have. We have a lot of them, but these are recommended to be used. Okay, now the challenges we have spoken yesterday in terms of challenges that we do have in the amputation rehabilitation. Again, one more challenge here is lacking the specialized pediatric rehabilitation services and limited access to child-friendly prosthetic and orthotic devices. And this is a real issue everywhere. The educational and the social challenges faced by children with the limb differences, especially when they engage or at the school age, and then when they engage more in the community, these psychosocial problems will appear more. So, generally, if we need to intervene to address this problem, we have to encourage and advocate for early interventions and multidisciplinary care. We have to support the families. Sometimes they need only reassurance. So we have to provide that in an appropriate manner because it's a journey. When I see a patient, like the first couple of months with his family, I always try to educate patient about, the patient family about the long journey that we are going to go through over many, many years. So they have to understand that, and they know what is at each stage, what is the potential intervention and what are the outcomes and what is the expectations, and you provide the appropriate reassurance but again, it has to be realistic. So don't give false hope for the patients, patient families, but make sure that you provide the appropriate counseling and provide the appropriate support in terms of follow-ups and the access to care. Now, these are detailed strategies. So collaboration between specialized healthcare providers and policymakers. Again, policymakers are the primary target for addressing such issues, and implementing early screening is very important intervention. I do receive a couple of patients on a weekly basis, very young, a couple of months in age, and we start with them the appropriate intervention, but this is not available everywhere. So we have to have that practice to include the patient early, look for the limitations, start with appropriate intervention, refer for a facility where they have appropriate intervention, especially if we lack the certain components that are not available within an institution, or there is no well-trained specialist dealing with those patients. Development of child-friendly environment and space is very, very important, and we lack that, unfortunately, everywhere, with a couple of exceptions. Training rehabilitation professional in pediatric care is important. I told you these are the most important things. having a trained specialist is totally different. To be trained in amputation rehabilitation, this is very important. In addition to that, he or she has to be trained to deal with the children, which is challenging. Providing comprehensive psychosocial support, involvement of appropriate healthcare providers to assist, like social workers, psychologists, to assist at that age for the family, and to collaborate with educators, schools, to promote the inclusion of disability. So, take-home message: the development of specialized care is crucial for success, incorporating providers trained and comfortable with children with limb amputation and limb difference. That include BMNR physician, prosthetic, pediatric, PT, pediatric, OT. It's very important to have the specialized pediatric or trained to deal with the pediatric cases. In addition to the other disciplinary, interdisciplinary is very important in terms of care coordination with, even for example, for a patient with the limb difference, sometimes you need to tackle a certain surgical intervention as they grow up, so you have to coordinate the care appropriately for those patients. Having a family center clinical team facilitates the communication. Despite the advancement of technology, procedures do not mimic normal functionality or cosmesis. This is another take-home message. Whatever we have in terms of development, again, it's not replacing the normal side. The expected use, cost, benefit, and ease of operation must be guided the prosthetic decision making. And I've told you how to deal with these restrictions in the previous slides for some of the main challenges in terms of regulating the follow-ups, addressing the issues with while patients are growing up rapidly, and so forth. The other thing also, the child who functions better without a prosthesis will most likely reject one. So this is not a failure. It reflects a functional success. So please focus on task-specific interventions, whether prosthetic or non-prosthetic, in order to succeed with your intervention. Finally, and most importantly, continued reassurance is very, very, very important for the family, and that would support when the provision of appropriate support is critical throughout the age. Thank you so much. Thank you.
Thank you so much, Dr. Faiz Al-Shahri, for the fascinating presentation. Now I would like to invite our next presenter who will share about the surgical management of post-amputation complications. Once again, welcome our guest speaker, Dr. Hussein El Jaad.
Thank you so much. Thank you so much. Start. Okay. Sorry. What's wrong with it? Good afternoon, everyone. It's me back. Thank you so much, Dr. Amel. I'll have to leave soon, so there was a bit of change in the schedule, but I hope I did not interrupt the whole thing, hopefully. Okay. Now we have done the amputation for a reason or another, and send the patient for the rehab. However, it doesn't mean that it's the end of the story. We will receive the patient again and again for a reason or another. We'll take a quick look on them, then we'll see how can we help the patient. First, psychological impact. So, let's say underestimated in our practice the psychological impact of the amputation. The how do the patients look at themselves. It's really huge. How can we deliver the message? Because the minute we say we'll have, which usually say it in Arabic, بنبتر الرجل أو بنبتر الصبع, it's a catastrophic word when they hear it. The end of the world to them. I will not go into the management or how to deal with it, but I believe it was or will be talking about. However, it has to be appreciated from our side, the way we deliver the message to them. We have to appreciate the word that we are saying and how to give a good justification to what we are planning to do. We are taking a valuable part of their body, and they will have to compensate for it by exercise, by having appointments here and there. It will limit their functionality. They will be exceptional for the rest of their life. So this, in terms of loss of sensation of the amputated limb with the phantom, sometimes and a few days after the amputation, some of our patients, they present back because they woke up from sleep, forgetting that the limb is amputated, they will start walking. They drop, they will cause trauma to themselves, right? So they will have the loss of the sensation of amputated limb, loss of the function, the change of the sense of body image when they look at themselves. So all of these might lead to depression, anxiety, denial. They will not believe it. And that will lead even to refusing physiotherapy. We do sometimes refer patients early on post-op to rehab, but they refuse to come because they are already in denial phase, right? Then the grief. And these symptoms or these findings or these syndromes that the patient will develop, it's not him only or her only. This will be in their families as well. And we have seen a lot of patients being ignored completely after the amputation. We have two extremes, honestly, in our society. Somebody will have full support by the family, and every day will have 4 people coming with them to the rehab or to the next appointment or attending with them in the hospital, while the others, you will see nobody completely. So that has to be taken in consideration big time. And honestly, sometimes when we have morbid obese patients, I tend to try to save the leg more because I think they will have hard time getting into rehab and using prosthesis. Morbid obese patients. Sometimes patients without enough support. When I notice that they don't have support, they present to the clinic alone, they present in the hospital, we do feel sometimes empathize with the patients, and we consider that even when we decide the amputation. The next complication, wound complication, disruption. We have it acutely or on a chronic basis. So in acute phase, usually ischemia and a proper assessment of blood supply of the leg, or choosing a proper level of amputation without revascularizing the leg. So I cannot assume that when I do transmetatarsal amputation and close it primarily without reaching or delivering or assuming the flow down to the foot, that wound will heal. And the problem, if we go back to the morning session by Dr. Maha or me, that most of the cases are diabetic. Problem with diabetic, they have poor wound healing. The function of polymorphonuclear cells, macrophages, other immune system is very poor, very weak. And the requirement of oxygen saturation at the level of the wound is higher. Like if you compare non-diabetic to diabetic patients, if the oxygen saturation required is 30 to 40%, in diabetic patients we need like 60, 70%. So the sentence that we use always for a wound to heal, we have to have pulsatile inline flow from heart to the wound. We have to treat every single occlusion or tight stenosis either by endovascular open or combined. Without doing that, the risk of wound healing or disruption of the wound is very high. It's just temporizing agent. You know that the end of the next day or the third day, you will see the wound is ischemic or the edges are ischemic as well. Next is poor surgical technique. That message is for me, for sure. Excessive pressure, tension on the wound without proper surgical technique. Poor hemostasis. We left the patient with who is on anticoagulation for his vascular problem that we finally decided it failed. Next is amputation, but we did not stop the anticoagulation, or they have renal failure with coagulopathy. These things have to be taken in mind when we close the end. If we have to put it in, we have to put it in, but we cannot risk the wound. Delayed wound healing because of being immunocompromised, again, sick patients, and malnourished patients, and superimposed infection. We have to be careful when we decide about the level of amputation. Again, when we decide that the amputation level, one of them, the extension of the infection. We cannot just cut on infected level, or if it's questionable, always leaving it open for some times and delaying the repair or to close later on. All the delayed primary amputation or secondary intention. Okay, so specifically again, because I'm in love with below-knee amputation, big fan of below-knee amputation, so I just made a slide only for below-knee amputation and wound problems in below-knee amputation. First thing, this relationship between me and below-knee amputation has to be balanced against the risk of wound failure. Right? So, and we have to be open and clear to the patients. Like when the patient has open common femoral artery, open profunda femoris artery, but the superficial femoral artery is occluded, the chance of healing the limb below knee stump is 70%. To me, it's a high percentage, keeping in mind the advantage of keeping the knee. I would take that risk. But it's not me taking the risk, it's the patient. So I'll have to explain to him that risk. If there is anything I can to optimize or improve the blood supply, good and well. If not, I'll explain to him, I'll go, I observe, I'll tell him that decision below versus above, I leave it to the OR. When I open, I'll see the amount of bleeding and how healthy are the tissues. If the skin of the calf is warm, free of trophic changes and infection, tissue bleeding is adequate, and primary healing after below-knee amputation is very high. So these are indirect signs. For whoever is not specialized, these are enough to give you the hint that the chance of healing is high. Wound breakdown occurs in about 20%, and I said 30, so 20 to 30, of all below knees and require conversion to above knee level. But the advantage is, once it healed, the chance of breakdown at later stage is 4% only. It goes dramatically down from 30% to 4%. So as you can see here, the profunda femoris artery is affected, right? And the common femoral. And if there is any chance that, and 100% it's important to me, and it's not a big procedure, femoral cut down, removing the plaque, doing the patch repair on the artery, will resume good blood supply to profunda femoris artery, and it will change it from below knee amputation. And either to start with, stage. Sometimes if the patient is not actively bleeding, as we said, if the patient has no active to revascularize, always revascularize first. And this is a picture of diagnostic angio to make sure there is nothing. If you have a question, as we said, this is the gold standard. Even if the CT angio says it's clear, then it opened up we might need to either repeat the CT angio or do on-table angiogram. And we have done it, above knee amputation, ischemic stump, we were in doubt, so we went from the other side, we did on-table angiogram. There was stenosis at the external iliac artery, which we opened. So as I said, it's either at this point, angioplasty and stenting versus bypasses. And some of the surgeons will feel, let's say, wouldn't take that amount of effort to change it from above knee to below knee, or even transmetatarsal. It's significant how important, I cannot overemphasize how important doing procedures just to make the amputation more distal. We do explain to our patients that amputation is a must. At this point, it's two amputation. But to heal that stump, I have to do that bypass. Unfortunately, some of them, they said, okay, what's the point of doing a bypass if I'll end up with amputation anyway? So here it comes the rule of rehab, rule of us as well as social worker to explain to them that it's a huge difference between transmetatarsal versus above knee amputation. And to change it from above knee to transmetatarsal, I have to do that bypass. I'll have to open the other leg. You can imagine me explaining to the patient that I'll have to open the whole leg on the other side, right? Taking the great saphenous vein and use it to the right leg to save it. So he will end up with two huge wounds. So it takes some effort to explain to them, but hopefully they, or most of the time, they do appreciate that and I understand it, and we succeed in decreasing or making that amputation more distal. So in the late breakdown, it's either deep infection that was not recognized earlier, and it took that time to open and to come out. It's associated again the progression of his peripheral or her peripheral vascular disease, diabetes, or amputation for infected hardware. If we use like knee replacement and it got infected, if we do the amputation for it, the risk of later on infection and breakdown is higher than the others. When the skin is very adherent to the subcutaneous tissue and the muscle, the third is, and again, the location of the scar. And third thing, I'm sorry to say it, guys, it's your territory, poor prosthetic fit. So you are, either you can make our life way easier, or you make it more difficult, and we have to deal with it. We have seen it, honestly. And they have a lot of ulcers at the stump down. So how do we manage it? Debridement, if needed, antibiotics, local wound care. We leave it for sometimes delayed healing, provided that there is no osteomyelitis, no extension of the infection to the bone. And for sure, last resort, we have to do revision amputation, like when there is only minimal length remained from the tibia, for example. Then we'll have either to do trans knee or above knee. Stump pain. I will not go into detail in it, but I'll give a few touches about it. We have it acute and chronic, immediate post-op. So best thing is PCA, patient-controlled analgesia system. And what's better than it, when we leave a sheet in the, when we leave a catheter in the nerve sheet for to deliver local anesthesia directly at the nerve, it decreases the need for opioids and post-op analgesia significantly. Honestly, somewhere it's a standard. We don't complete any below knee or above knee without this, but here our practice is really short of that, honestly. Severe and prolonged perioperative limb pain. Again, if we delay the amputation, patient has chronic wrist pain, non-salvageable. You cannot revascularize it. It's not fair to him or to his family to delay the amputation for a quite long time and to the acute phase. In below acute phase, in below knee, they will stay in one position and they will refuse to move it, and they will end up with at least mild flexion deformity, at least. So proper and good post-op analgesia will allow the physiotherapist and the rehabilitation specialist, when he comes, to exercise the patient well and to keep the muscle healthy, strong, and to avoid the joint flexion. This is very important as well. It limits the ambulation and increases the risk of complications of recompensating, including bed sores and others. Neuroma. As we said in the morning, some will be exposed to some form of neuromas, most of them, but is it enough to cause pain? Is it enough to limit their functional status or not? It depends on the other factors. Poor surgical technique, again, we said pulling it for a good distance, cutting it under stretch, and then it retracts significantly above the level of the bone, so it's away from the prosthesis. Because if the prosthesis is compressing on that neuroma, definitely it's going to be painful. But if it's higher, as Dr. Fayez said, the post-op pain or post-analgesia or prosthesis-induced pain will be higher in the lower limb because of the weight bearing in comparison to the upper limb. So trying to keep it as far as possible from the prosthesis will decrease it definitely. High pressure area if it's not distributed well. And they noticed it with the indication of amputation, if it's crush injury versus elective or ischemia or diabetic cause etiology of amputation, it's less than. They have neuropathy anyway. The chance of having post-amputation pain is less. Okay, bone spur and heterotopic ossification. It's more associated with severe trauma, again, same with the neuroma, and because of, again, poor surgical technique from our side, excessive manipulation of the periosteum. I'll have a touch later on the bone spur and hypertrophy. May require surgical resection of problematic bone. So, stump overgrowth in children. It's a special identity that I preferred upon request of the scientific committee to give a quick touch on it. So, it's the most common complication in pediatric age group. We don't see it in adults. We see it mostly in pediatrics. And it varies between 4 to 5%. And you notice the age. So if the amputation happened above the age of 12, it's unlikely, almost never. Some literature says never in the age above 12. And it's more common, and you will see it frequently, in the patients younger than the age of 12. Okay? And you can notice that it's never reported in patients post-disarticulation at the level of the knee. We'll talk about a hypothesis that explains why this happens in pediatric age group. Overall, the location of the stump overgrowth more in the humerus, followed by the fibula and tibia, rare in radius and ulna, right, Doctor, as we said. So, regarding the indication, they said it's more common in traumatic, higher risk than elective. Okay? Previous surgery for overgrowth, metaphyseal amputation, higher risk than the physeal level of amputation. These are the characters where we find it more commonly. Traumatic, previous surgery of overgrowth with the recurrence and need for further procedure, and the level bony-wise. So, first hypothesis. Disproportional growth between the remaining proximal physis and the contracted distal soft tissue and skin. Right? So there is growth in the bone, but the soft tissue is not growing as fast as the bone. But the answer is, why it happens only or more common in trauma? They share the same mechanism, right? If we amputate at the exact same level for trauma versus elective, the trauma has higher. So if the reason is disproportional growth, it should be the same on both sides, right? Moreover, the disarticulation, why it never happens in disarticulation. Third, they try to manage it with leaving more redundant skin and subcutaneous tissue, so they prevent it to happen, but again didn't work. Still, they will have overgrowth of the bone beyond it. It didn't fix it. This is the first theory. They say the second theory, it's an inflammatory reaction to the amputation. And especially with trauma, the magnitude of trauma is higher. So this will explain why it happens in trauma. It doesn't happen in disarticulation. The question is why it does not happen in children and adults. If we get an adult with traumatic amputation, they don't get stump overgrowth. This is the second theory. Third theory, which is the most acceptable one between brackets, it's the immature nature of the skeleton, the membranous skeleton. Gets attracted by the inflammatory reaction around the stump. So this is why it's different. This articulation, that one is not exposed. In the adult, less likely it's already calcified, or mature skeleton. But in the younger patients with the membranous periosteum, the chance of getting affected by the inflammatory reaction is higher, and it's being pulled down by the inflammatory reaction. So diagnosis will be, patient will present with pain, will not tolerate the prosthesis before he used to be fine with it and use it without any difficulties. Soft tissue irritation, then will start to develop pressure ulcer, skin perforation, or sometimes it's just infection. And diagnosis with X-ray, you will see the bone spike, can be palpated by subcutaneously or by X-ray, right? And of course, we need to rule out, in case of pain mainly, we need to rule out other causes like neuromas and the others, right? Or deep infection. So, prevention and management. First, conservative management, first line of management in anything. Prosthesis and lifestyle modification, as well as the skin revision. The prevention with the prophylactic transplantation of ischiochondral graft to plug of the stump, recommended when a graft is available. They recommend that in every trauma patient, if the amputated part is there, to take the head of fibula and use it to cap the end of the tibia, and to make it standard for all patients with traumatic amputation or non-traumatic, except if it's for infection, which is not common in kids. But whenever it's available, the head of the fibula to be used to cap it. If it's not there, other options are available, be it synthetic like Teflon or the epiphysis of the crest, iliac crest. So, I don't know, it's not clear. Anyway, so the rate of the need of a future revision is significantly lower if we use the fibula capping. It's less than 20%. If we use the iliac crest, then it's around 40%. If we use synthetic, it sometimes reaches 70%, and patient might need like 7 times revisions, up to 7 revisions. The reason behind the synthetic is not working is that the rate of infection is higher, and the dislodgement, it does not stay where it's supposed to be. Joint contracture. Again, quick talk about it. It's usually if we leave short liver, which is the distal part, or distal to the joint. The longer you keep or you leave, the less likely the patient will develop joint contracture. Knee fixed flexion deformity of more than 20% necessitate increased hip flexion, lumbar spine extension, which makes mobilization difficult. It significantly affects the walking and the use of prosthesis. When it's less than 20, usually it's acceptable, it's manageable, can be improved with you guys with the physiotherapy and rehab exercises. But when it's more than this, contracture release and tendinolysis may be required. Poor fitting of prosthesis will lead to unequal weight load to the lower limbs, extra stress on pressure, either on the other leg or in the stump, pain and skin problems. As we say, the skin breakdown. One of the reasons is improper fitting of prosthesis, and we might need revision amputation. This is a very rare but significant complication that you need to keep it in mind. Sometimes a fistula might develop between the artery and the vein, especially as we said, we just suture ligate them together, or it's a pseudoaneurysm of the artery. Its management, again, the presentation as in the upper picture that you will see that it's swollen, the stump is swollen, it's poorly fitting, sometimes it's painful. You do an arterial study, be it Doppler, CT, or on-table angiogram, you will see that the distal end of the artery is being big. Actually, it's a form of bleeding with the repetitive trauma. If I don't shorten my artery enough as well, just similar to the nerve, repetitive trauma to the artery might cause this. It's a minute bleeding that will develop with time, and hopefully it does not rupture. Management endovascular is very easy and can be just completely cured. It's just like plaque with endovascular that stops the whole thing. Okay, so amputation site prominence, we said it's either overgrowth, bone spur, muscle atrophy, failed myoplasty, myodesis, skin hypertrophy, parasitis, pulpus, floppy residual limb, poor surgical technique. كلهم في النهاية احنا يعني. It's all poor surgical technique plus the poor fitting of the prosthesis. For a reason or another, we have to just look at it, assess it, and see what's the reason. If conservative management with modification of the prosthesis is enough, good and well. If not, we have to do revision amputation. By the way, revision amputation, I'll talk about it later, the indications. It does not mean always that I'll have to go above knee, from below to above. Sometimes it's just getting rid of the extra skin and subcutaneous tissue. Nothing more. That's it, which is more than enough, and patient will be back within like 3-4 weeks using the temporary or using the permanent prosthesis accordingly. Poor fitting of prosthesis. Why it's here again, sorry. So indication of revision of amputation. First, tissue prominence, either causing poor prosthetic fit or limited function, excessive pain, or skin at risk of breakdown. I don't wait for it to happen, so I'll be one step ahead of the patient and I revise the stump. Second, neurological complications. When all the conservative and non-surgical measures dealing with the neuroma and phantom leg fails, then I'll have to intervene surgically. And that's it. Thank you so much.
Thank you very much for Dr. Hussein El Jaad for the time and effort in preparing 2 presentations for us today. And now I am pleased to announce the next speaker who will be presenting about the role of physical therapy in pre-operative phase in person going through lower limb amputation. She is a physiotherapy specialist. Please give a round of applause to Miss Asma Al Ghamdi.
Hello, good afternoon, and thank you all for attending this scientific event and for your commitment to provide the best possible care for patients with lower limb amputation. I'm Asma Al Ghamdi, a physical therapy specialist at the Damam Medical Complex. I will be discussing the role of physical therapy in lower limb amputation patient. Mr. Abdullah Mashkuran, he already covered a lot of points on this topic. I hope to provide a brief and valuable insight on this topic. What's the pre-operative physical therapy? As we mentioned a lot yesterday, the pre-operative physical therapy is a specialized rehabilitation program designed for individuals with lower limb amputation. The aim of this program is to provide both emotional and physical support for those type of patients to improve the rehabilitation outcome following the surgery. The importance of pre-operative physical therapy lies between the ability to provide both physical and emotional support for patients by helping patients to improve their physical function and increase the flexibility and endurance. It's also engaging in physical therapy, comprehensive program, helping managing pain associated with underlying condition. It's provide psychological support for patients as well by alleviate the anxiety and promote the emotional readiness. Education on rehabilitation and the prosthetic uses to ensure that the patient will informed and ready for the surgery. In physical assessment, in the comprehensive physical assessment, we start by reviewing the past medical history and underlying conditions such as vascular disease and diabetes. We're also reviewing the past surgical history, analyzing medication to promote smooth recovery outcomes. When we talk about the physical assessment, we start by observing the posture and gait to identify any abnormal pattern and limitation that impact the rehabilitation expectation. We also measure the range of motion to identify any limitation, and we conduct a strengthening test for the major muscle group to identify the patient's capacity for the exercises. Finally, we evaluate both static and dynamic balance to determine the patient's stability and ensure safe movement. In the functional assessment context, we start with assessing the functional of the ADL or daily activity like dressing or bathing. After this evaluation, we utilize the FIM tool to quantify the independence in performing daily activity. Evaluating the patient mobility assessment, like walking and uses of assisted devices, including also in the mobility assessment. In the pain assessment, we start with the pain level evaluation by using the standardized pain scale, such as numeric rating scale or visual analog scale, to determine to quantify the pain intensity and how the pain affects the physical activities. Following the pain assessment, we can use some pain management strategies, including pharmacological approach such as medication, and non-pharmacological method like physical therapy or relaxation exercise. The psychological evaluation contain these three key elements, including the emotional state, and it's including evaluating the emotion for the patient and determine the anxiety or depression or any factor that affects our goals. Also identify the support network, including family or friend or community, and how can this individual assist in the rehabilitation journey. Evaluating the patient understanding of surgical process and the post-operative recovery, including the prosthetic uses and the rehabilitation expectation of this and the rehabilitation expectation for each individual. The goal setting is a helpful process for both a healthcare provider and a patient toward achieving the great outcome by using the SMART goal. SMART stands for specific, measurable, achievable, relevant, and time-bound. Goals may include improving strength, reducing pain, and increasing knowledge for the post-surgical phase. The interdisciplinary collaboration, including team approach by engaging the rehabilitation physicians and the surgeon, occupational therapist, psychiatric, dietitian, and physiotherapist to set a realistic goal for patient to ensure a comprehensive and coordinated plan of care. The communication between these teams by discussing and evaluating the finding with the healthcare to align the treatment strategies and enhance the patient's outcome. Establish clear goals for patients to optimize outcome for patients undergoing lower limb amputation. These goals including some primary, like enhance the physical strength by focusing on the remaining limb and the upper body, improving the range of motion by increasing the flexibility in the joint and the affected area, enhanced balance and coordination, facilitate pain management, as I mentioned, using a pharmacological and non-pharmacological approach, promote psychological readiness, and set realistic post-operative goal for the short term and the long term. Tailored or creating a tailored exercise program for patients undergoing lower limb amputation involve focusing on three key areas, including the strengthening, flexibility, and balance. Each program should be customized for the patient ability and needs. The exercise program including strengthening exercise to enhance the muscle strength in the remaining limb and the upper body to support mobility and activity of the daily living. There is some example for the upper body exercise such as seated row or biceps curl and triceps extension to improve the upper body strengthening. The core strengthening like plank or bridging exercises to improve the trunk and core strengthening. The balance coordination training to improve and prevent the risk of fall. A static balance exercise like standing on one leg, and dynamic balance exercise like using a balance board. The aerobic condition it's helped to enhance the cardiovascular fitness and overall endurance to prepare the patient, the physical demand of recovery, like low impact aerobic exercise such as walking or swimming, and walking program by using or without using assistive devices. The functional training to prepare the patient for daily activity and movement. They need post-surgery, like a transfer from bed to chair or from sitting to stand. And the ADL simulation help patient like reaching objective and dressing. The pain management exercise, it's help to promote the relaxation for patient by gentle range of motion exercise and stretching or deep breathing exercise. Here's an example of some exercises program customized for individual need, including each body part and the set of repetition. For the upper body strengthening, seated row, biceps curl, and triceps extension. For the core strengthening, like bridging and plank. For the lower body strengthening, leg press for the remaining limb and stand to set. The frequency 2 to 3 times per week within 2 to 3 sets of 8 to 12 repetition. For the flexibility program, the hip and knee stretching, including seated hamstring stretch, knee to chest stretch. For the upper body stretching, shoulder stretch, triceps stretch. For the ankle and foot stretching, calf stretch, and ankle circle. The frequency daily or every day, holding stretching from 15 to 30 seconds for 2 to 3 times. For the balance program, the sample exercise, static balance exercise like single leg stand, heel to toe stand. For the dynamic balance exercise like tandem walking and side stepping. The functional balance exercise like set to stand and reaching exercise. 3 to 4 times per week for 10 to 15 and holding from 10 to 30 seconds. The uses of assistive devices is not only to enhance the mobility of patients, it also helps patients to maintain their functional abilities and prepare for the post-surgical phase. The planning for the post-operative rehabilitation. Effective planning for post-operative rehabilitation is important for the lower limb amputation because it's played a significant role in preparing patient for the transition in post-operative care by setting the realistic expectation and ensuring a collaborative approach to rehabilitation. preparing patient for the transition to post-operative physical therapy, including education about the rehabilitation process, familiarization with the equipment, and goal setting. Okay. Setting the realistic expectation, recovery, and rehabilitation by understanding the recovery timeline and addressing the common challenges the patient facing, highlighting the importance of patience and persistence. The importance of the multidisciplinary approach, including collaborative care, as I mentioned, engaging the medical team and holistic support, continuity of the care. By integrating the best available evidence with the clinical expert and patient preference, healthcare provider can make informed decision to lead to improve the patient outcome and satisfaction. Here, there is a study about the preoperative rehabilitation in lower limb amputation patient and its effect on the postoperative outcome. The study found that preoperative positively influenced post-operative mobility. 63 lower limb amputation patients reached at least indoor mobility with the use of assistive devices. This result was attributed to the inpatient-based rehabilitation program, which was offered to the lower limb amputation patient on a daily basis before the operation. So before ending, I would like to recommend adding this program to our clinical guideline to improve and optimize the outcome of rehabilitation process. And thank you.
Thank you, Ms. Asma, for sharing your knowledge with us. And now I would like to invite our panelists back to the stage to start the discussion panel. Ms. Asma Al-Ghamdi, we will start the discussion, panelists. Thank you so much for the remarkable presentations for today. And now I would like to open the floor for questions from the audience. Please, if you have any questions, can you give the mic to...
Thank you so much for your presentations. I have a little concern about how we can engage the prosthetist in the pre-amputation and post-amputation stages. So, concern about the amputation, if we discuss with the prosthetist how we choose the level of amputation, like whether below knee or above knee. At the same time, sometimes there is a wound at the end of the residual limb or around the residual limb. So choosing the right socket, which is the part of the prosthesis, is really crucial. How we make the design of the prosthesis. So maybe this will affect how to choose the amputation level, and at the same time how we can manage this skin breakdown or the wounds. So my question is, have you engaged any prosthetist in pre or post amputation stage?
Sure. The question is tricky, but I'll be honest, as I always. I have never engaged any, in my practice, though I do appreciate the suggestion, and the better practice is to choose what level we will amputate. If he comes or she comes and assist the patient, I'm saying that this patient is non-salvageable, I cannot offer him any revascularization anymore, still having severe pain, or the wound is not healing, it's time to amputate, right? And then options versus below versus above, and to pick the size. Unfortunately, though, it's good to come and pick a place which is better for prosthesis. We are not doing this for the reasons. We are really lousy to do this, lazy to do this, إحنا بصراحة, honestly. This is one. The second point, the rehab people, let's say, do we have plenty of them again to come and see and assist the patient properly and to suggest the right location? Second question. Third question, as I said, sometimes we consent the patient for around knee amputation. We don't even specify below knee versus above. Moreover, how can we decide the level exactly below the knee? Sometimes hardly, I cannot again with the extension of infection. Like I consent the patient that exploration of the wound below, possible above. It's sometimes we open, which is, I didn't put a lot of pictures, but sometimes the patient comes with distal tibial or distal leg infection. When I open, it's extended all the way to the toes, up to almost the knee. Like I amputate above knee with some fluid edema because of inflammatory response. I take the risk with the risk of possible stump infection, but trying not to go higher above knee. So how much it's applicable to do that and to stick to it honestly by calling you, wasting your time and effort, and you will put that idea more or less to the head of the patient, then post-op, he will come and ask me why you didn't do the amputation exactly as was said by the physiotherapist or the rehabilitator, right?
Exactly.
So will put me in bad shape as well.
Thank you so much. So this is a little concern because sometimes I think we have lack of communication. That's why sometimes we need your suggestions about how we can manage the patients from the prosthetic side. So if we get a lot of information, advices from you as a surgeon, this is really important for us to make a great prosthesis for a patient, choosing the components and choosing the right socket for this.
I couldn't agree more, but honestly, multidisciplinary team approach, it's written only on the presentations. Most of the time. Sorry for that comment, but it's true. When we approach cancer cases, we do multidisciplinary team. We get oncology, radiotherapy, we get histopath, radiologist, and in some centers only, not all centers. But when we deal with patients, when we call for family meeting, we call for multidisciplinary team, sometimes they are asking why. We just wrote our recommendation, why you are calling us? We don't communicate, even planning the type of anesthesia intra-op for the patient when he's sick, how to be one step ahead of the patient, how to be one step ahead of the whole scenario, calling standby ICU, standby physiotherapist if I need immediately to bring the prosthesis that I might require, or braces. Unfortunately, we lack the effective communication in our practice in all terms, all levels.
Thank you so much.
No.
Thank you.
Just add a comment on that remarks. I totally agree with Dr. Hussein in terms of the poor communication. This is like everywhere, unfortunately, but it depends again on the institution. So if the institution provide the acute services and there is enough staff to deliver the pre and post rehabilitation, this is the ideal level of care. And in case for elective like surgeries, it's always advised to have like a pre-amputation evaluation, but sometimes it's difficult, and as Dr. Hussein said, sometimes during the operation there will be another factors that will change the equation. So we have to keep all this in mind, but definitely then it's again, it's a mentality of the institution that brings all the appropriate discipline working together that will be reflected on patient outcomes.
Thank you for the nice presentations.
Thank you so much.
I have a question and comment regarding the presentation of Dr.
Sure.
Dr. Shahri. Regarding the congenital amputations, we frequently receive parents with their children. They are 2 years old, 1 year old, 3 years old, asking for prosthesis. For me, it's inappropriate age to provide prosthesis. Why? First of all, congenital amputation, there is no image of the limb in the cortex, okay? There is no somatotopic representation. That's why he cannot integrate the prosthesis at this age. He doesn't know what does it mean. And second thing, it's for him, it's foreign object, okay? Foreign object is difficult to integrate it to his body. That's we explain to the parents that it's not the appropriate age to receive the patient and to provide the prosthesis. And for some of them, it's very difficult to convince them. They think that earlier will be better for the child to get the prosthesis. Or for me, the process will be mainly a foreign body which will not be integrated by the patient. That's why the somatotopic representation is very important. When it is acquired amputation, it's easier for the child to integrate the prosthesis. But when the child is so young, it's very difficult to think prescribing a prosthesis. I don't know if we are on the same page.
Well, I do agree with like certain components, and for the other parts, I mean, definitely some of those, even early, we can reintegrate like some prosthetic interventions if, again, it's linked to a specific function. For example, I mean, those who are like, if I received a patient who was as early as like 6 months for upper limb amputation, I would, sometimes we receive cases, but it's not always the case. It's encouraged to start to initiate some upper limb like prosthetic intervention. The goal is to assist the patient to sit appropriately, so that, or to assist the patient to achieve that goal, the milestone. So for that function, this is appropriate intervention. I didn't highlight the like at the age specific like interventions, but this is one example. When the patient is, for example, for lower limb, a patient by age of 1 year, even before that, sometimes I initiate like by age of 9 months, I do that, but they have to provide the appropriate like intervention to aim to support that milestone, which is to stand and then to stand up and to start to initiate the walking by age of 1 year. So if it is linked to the function, most likely the patient will use it. But however, for some like interval periods, especially for upper limb, you are correct, those will have they will reject the prosthesis, which is expected. I mean, they are at an age that they are developing the sensory, the neurosensory development, which is expected. I mean, with the pediatrics development, for that age, it's not advised to initiate unless there is a specific function you would like to achieve. And always I have difficult discussions with the families with regard specifically for the cosmetic intervention, especially the high definition prosthetics. These are interventions which takes time, I mean, for fabrication and delivery. So for those patients, we opt not to initiate these type of interventions until the age of 4 years, where the growth is appropriate enough to initiate such interventions, and the maintenance part, meanwhile during this age, like a group, the growth over these couple of years will be linked to the milestone. If there is milestone, growth milestone I would like to catch or achieve or facilitate, I will push for that. But if the patient, for example, came to me like at the end of the first year and asking for upper limb just to, there is no functional goal, for example, to pull to stand, so that one already achieved, I might skip that goal and I'll look for more functional goal at a later stage.
Yeah, we are in the same page, but some people, some parents cannot understand that the patient is using his stump, is using his stump as normal hand. Especially in the congenital amputations, it's an obstacle for him. The process is an obstacle. The parents are pushing the child to have the process as early as possible, but finally they don't help him. I think it's much better to wait as much as we can, then we provide the process. Regarding the lower limb, no, it's different. Lower limb at the age of walking, it means from 9 months to 18 months, it's recommended to start as soon as possible to provide the prosthesis.
Yes, I totally agree, especially for those who have like a functional abilities and certain, even if it is like a limb with congenital malformation, but it's functional to achieve that goal. I always discourage to intervene with because whatever intervention you will do, it will limit or restrict the function.
And this, I can suggest that it's coming from the cognitive load. That's the patient, the burden after all of this. I read an article saying about comparing between bionics and passive hands and the body-powered kind of prosthesis. So it comes from the OT, the occupational therapy, to go with the 10 blocks or all exercises. They teach the person how to deal with this, because it's hard to go. And I always say, what does intelligence mean? It's the way how to people adapt to the situation. And like people, they adapt with what we have. Who has a why can bear anyhow. So they go with the how while they are bearing anything in life. So why I add something to my life that will keep me like it's a burden for me. So that's why they go with the passive hand, high definition hand, because it's cosmesis, and they psychologically they will go good with it. So from a manufacturing side, product side of it, so I will go with passive hand. Why I go more complicated with bionics and etc.
Yeah, exactly. And even the evidence for bionics or myoloctic, it's like age of 2 or 3, the best, like, I mean, earliest intervention, which is even difficult to match the component, the weight. So that's why it's better to defer such intervention and focus on whatever is functionally appealing.
And one of the things that I will add, bionics are not bionics. Bionics are myoelectric. So
yes,
it's electrodes. But the upcoming days with all of the with how there is a study in MIT in Boston, they are trying to get all of the tracts that's happening on the brain and mimicking. They call it angiography of the brain, and they want to mimic it to have like algorithms and they have a program to get all of these signals to the hand by itself from the brain. And this is really well promising thing, because really the bionics, my body board, it's get a lot of cognitive load. the patient is goodbye, I don't want to use it.
Exactly, and this is maybe in future because I think the yesterday discussions we touched only the primary suspension options. However, in future we'll have like more and more options, including the BCI. The other like yes, exactly. Yeah, this is promising, but still
it's
under
really
like
I saw a video of a guy is working with his hand, with hand by getting it from his brain.
Yeah.
It's really cool.
Agree.
Any other questions?
Assalamu alaikum. Thank you for your presentations.
Thank you.
My question is to you, Dr. Hussein. I'm asking if you are performing targeted muscle reinnervation for controlling pain, and if you have any idea about it.
No, honestly, we refer them to acute pain service. we don't get involved after, which is really bad, honestly. Once the patient is amputated, wound is healed, we do send them to rehab, and we don't receive them except after complications or major complications. We don't hear even the feedback that what we have done is good or bad. Honestly, so the communication again is so behind. And we don't get involved except when the exhausted. And I think out of all the amputation we had one patient with chronic pain only. The rest of the complications almost were not there, except on the other limbs. When we amputate one leg, usually they come with a problem in the other leg.
Yes. Thank you.
This question is really important for me.
Deep in your heart.
No, important to me. Like, how many amputations do you do every week? Like,
oh my goodness.
That's really interesting for me.
If you want to hear sad stories, I have plenty of them. Almost we do it on weekly basis, 3, 4, 5 amputations. And 2 amputations, I have one unlucky lady. So what I'm weak in the front of patient with renal failure and pediatrics. So when I have one patient having those 2 at the same time, she's only 28 and diabetic type 1, she lost her kidneys around 7, 8, transplant failed, hypertension. So far in 2.5 years, I have done 5 angioplasties. 2 on one side, 3 on the other side. Every 6 months, I amputate one toe. I have hard time to heal that wound. And with that, I will definitely, if anybody happy to take over, to rehab her. She doesn't walk, hardly with the walker. I try to encourage her to walk because every angioplasty I do in 6 months, 9 months, because she doesn't walk, it gets excluded again. So we do a lot of amputation. We had someone who was like, within 8 months, 10 months, we amputated both legs above knee because of severe neck fash in both. We had most of our patients, once we amputate one leg, in less than 2 years, we amputate the other, 100% sure.
And all of this having a cross streets from here.
Yep. And I'm saying that it's less now than before. Less than before. Now we have more vascular surgeons than before. Like I have like 3 fellows outside, QCH, I'm the 4th among them. Before there was no one, almost 0. So any patient with trauma out. Damam Central, I think they have now 2 third recruited. Don't know how they are practicing. In King Fahad Specialist Hospital, they have only 1 for quite a long time. I had to work like for 3 years in 2 hospitals covering the whole day. I operated in Saud al-Babtain, I operated in the DMC, I operated multiple times in different hospitals because there is no vascular surgeon. So if we don't operate, the chance of amputating the leg is very high. And the amputation rate is so high. It's way more than what we believe.
Okay.
Excuse me to add something, because there is a vicious circle when you have this kind of patients. Rehabilitation cannot do the job because generally there is a renal failure. Renal failure cannot tolerate effort. There is heart failure which cannot tolerate effort. It means it will be mainly passive rehabilitation, which is not something which can give a good result.
So it goes back, and I'm sorry, Arwa, but just I'll add this comment. I'll go back to the comment of Dr. Faiz in the morning about doing below amputation and somebody who's not expected to walk again because of morbidities. My patients, I would say 80% of them, we have, if you have just to check the box of comorbidities, diabetes, hypertension, renal failure, heavy smoker, ischemic heart disease, post-PCI or CABG. These are my patients, 89%, 80% of the time. So if not renal failure, chronic kidney disease up to like grade 3 and 4. Diabetes, if not type 1, it's type 2, with all the complication. If not both, we have heavy smoker, hypertension, and all of them, we know that ejection fraction of them. Sometimes we don't do bypass and we do amputation just because his ejection fraction is 20. So we know that the bypass will fail the next day. So why to expose him to this surgery, major surgery, and we know that it will fail in 3 months. And I had to do this once in ejection fraction of 35% above knee amputation. Patient went to a complication after another till he dies. So you can't blame me because I gave him the chance to save his leg.
Okay, I think Ms. Zainab has a question.
Please.
Thank you, doctors, both of you, for the informative presentations. My question is regarding individuals with PFFD. As a surgeon, would you recommend doing rotationoplasty surgery for those people or keeping the limb as it is?
Allah, you used a very difficult abbreviation. So what is it, honestly?
She's referring for proximal femoral deficiency. Yeah, focal deficiency, which is one of the like congenital limb deficiency or changes that happen with the patient. And we have a lot of debates with regard to the interventions. But I believe it's primarily with the orthopedic surgeons.
Yeah.
It's not under the scope of vascular surgeons, but I can give some answers with regard to the intervention, because sometimes we receive patients and we counsel them for the appropriate surgery. One patient I received like 2 weeks ago, we didn't advocate for that surgery because the functional outcomes, the rotationoplasty was supposed to have like a functional knee. For that patient, for example, he was not fit. The knee, the ankle joint was not functional. So, for example, for that case, it was not appropriate intervention. It's not even as a surgery, it's not done everywhere, but it is one of the option of the managements for the proximal femoral focal deficiency or the longitudinal absence of the longitudinal amputation of the femur, whether it's partial or focal or complete. However, the decision will be also made according to the involvement of the hip joint. So we have to review all the associated factors, and based on the also primarily the prosthetic intervention will be the first step management, but for the coordination of surgery it depends on how much is the score for the involvement of the hip joint, and also the functional impact and the remaining part of the limb, how much is affected and where to, because the prosthetic intervention will be much easier with the rotationoplasty, but you have to decide the appropriate candidate in order to, but this is usually with the orthopedic surgeon.
Thank you.
Okay. Any questions?
Yeah.
The mic to Mr. Blady.
One of the things I didn't hear since yesterday, talking about the osseointegration.
Yes, this is another system of suspension, by the way.
Yeah. And the thing is that I don't know. This is from my ignorance. Has it been done in Saudi? Because I saw like 4 cases in the US, and I saw in the border of Ukraine, I saw many patients. There was a doctor who's adopting there to do a study of osseointegration at the border with the war.
Yeah.
But in Saudi Arabia, have we done this before or not?
No, actually, as of would you like to add a comment? Okay, but I have an answer for that question. But okay, sure. So in terms of osseointegration, it's one system of suspensions that can be utilized for the patients. However, it's not the primary intervention. It has to be one of the resources that can be integrated, and it has to be through a program. So if you have an appropriate program that collaborates, especially because it is an implant that's being like introduced to the body, it has to have like a clear pathway to select the appropriate patient after evaluation, and then ensuring the maintenance part, because it's going to be an implant with the patient. In terms of count now, this actually it is not a new procedure. It started in 1990 as a first like case in Sweden, by the way, but it started to be more and more common in Australia because of that guy who's advocating for this surgery, and now there is more than 1,000 cases like worldwide. But like, I mean, do we have it like locally as of now? I don't have like somebody dedicated, because they have to have the full like surface. It has to have the orthopedic surgeon involved and the rehabilitation team involved to select the appropriate candidate and go through a continuous long-term follow-up. This is important because, you know, the risk of infection, especially the first 2 years, is really very high with the exposed distal like part. The prosthetic intervention, it will eliminate the socket, so it will be easier to handle the distal components. But in terms of recommendation, it will be, for me, the last resort, unless we have like a local center that will develop this practice and will have appropriate guidelines and ensure the ownership of that and like long-term management, because it's not easy intervention. Sometimes the prosthetic intervention is much easier, more convenient for a patient as opposed to this intervention.
Okay, we will take the last question and we will stop for the prayer time.
Actually, it's not a question. It's kind of a comment for the osseointegration. I invested more and I dig deep a lot when it comes to the osseointegration. I got the privilege of being trained by Dr. Munjad himself,
okay, he's the
Australian
one,
in 2019. We spent almost 12 days with him. We attended almost 13 osseointegration surgeries. Yes. And it's really a promising opportunity, honestly, to have in Saudi. And I met him 2 weeks ago in Jordan as well. And he said that 2 doctors finished their fellowship with him, and they are located in Jeddah. Unfortunately, the implant itself is not being recognized by the Saudi FDA, and they are working, honestly, in this regard as well. We have only one patient that I know. He used to be in our facility, but decided to go to Australia because of his studies as well over there as in his scholarship, and managed to have the osseointegration system implants during his study. He is coming to us as a follow-up sessions to have some just minor adjustments. Unfortunately, us as a center or as a city, we don't have the like authority and things to provide any sort of materials that's needed for an adjustment. But inshallah, in the coming few, I wish to say weeks, but I bet it's going to be months or years that this will take a place. We tried and we proposed for hosting this procedure in our facility, but unfortunately, due to COVID and other circumstances, we stopped. But the communication and the connection between us and Dr. Munjad, honestly, it's a promising technology to have. When I went there in Australia, I focused a lot when it comes to the patient experience. And I met with patients before they get amputated, actually. So when we think about it, it's no socket at all. That patients might decide to go for the osseointegration after trying the socket and going with the dilemma of the socket when it comes to the wound, pressure, and weight fluctuating. I met with people who prior their amputation and they've decided to go straight away with the osseointegration because they've done their homework. They've had the privilege of meeting with people and which getting the point of Mr. Majid yesterday that the peer support and the group support is very important. The aspect of having the osseointegration and eliminating everything, even from the smallest details, like me as an OT, I go very much with the activities of daily living, and one of it is toileting and dressing, the lower extremity as well. It's much easier when it comes to the dressing itself. It's much easier when going to the toilet. It's much easier when it comes to the donning and doffing of the prosthesis itself. And yes, he did mention something that you will love it so much that you will only need to spend 15 minutes with the patient. That's it. No more socket, no more casting, no more any other aspect. It's only 15 minutes. And he even talked about the financial aspect of having, you can accommodate 4 patients in an hour instead of working 2 days to just finalize the 1 socket for a patient.
Yeah.
So that's really promising, and I'm really hoping to having this. And actually, when I talked to Dr. Amar, it came to my mind, inshallah, the next symposium or the next amputee event, we shall at least introduce the new technology. I know it needs more studies, more papers to validate and to prove the effectiveness of this procedure, but having the new technology, the resistance of not implementing or thinking about it is something, in my opinion, shall be like put on aside, especially if it's having great results with some patients overseas and outside the kingdom. One more comment. I talked to him regarding the infection rate. Yes. He said, I've implemented this procedure in Iraq for 150 patients. None of them reported any sort of infection for the first 6 months. And he said that in Iraq, they don't have even a clean water to shower or to clean themselves. So what's going to be the issue of having that, to have it in the modern societies and countries?
Thank you so much for your comment. It is a promising intervention, but again, I know there is any issues with regard to, because this is the experience maybe in Australia, because how much they provide, even the rotationoplasty, by the way, it's very common in Australia because they advocate and they do have a healthcare system that, make sure that all appropriate patients and the funding for such programs is available. So having such programs without ensuring the continuity, that would be struggle unless there will be a selected number of patients with the appropriate guidelines and criteria for the candidacy. On the other hand, definitely, function is going to make huge impact on the patient outcomes, especially with the range of motion. This is the simplest advantage for the osseointegration. But even more than the normal range of motion. By the way, you can achieve higher range of motion. Yeah, even more. You will have even better range. So this is the advantage. But again, because there are I believe 5 types of modalities that can be used for the surgeries. Even the surgical technique can be one surgery, or can be on multiple stages. So and there different advantages and disadvantages for each techniques. And again, the SFDA, the appropriate provision of selecting of the candidate, especially for example, for people with this vascular amputation or secondary diabetes or vascular, those are excluded in the past. For most of the cases, very, very limited cases are, but is now maybe going to change, but again, this is another risk that has to be considered importantly for those patients. So it is a good option for those patients who, and I advocate for it, if they have limitations with the socket like interventions, the traditional interventions. However, it has to be through an appropriate and like a pathway. The same it was in Canada, United States. They do have such programs, but it is within a comprehensive program that ensure the long time provision of the care. Because I remember, like, for example, in rehabilitation, we used another device, the intrathecal pump. Without appropriate long-term provision of the appropriate management, the patient might end up with life-threatening condition. But this is less like in case of rotational plasty, but we have to keep this in our mind, and patient has to know this is going to be the long-term care that he will need to...
Actually, Doctor, 2019, when we went there, it was one of the contraindication of not implementing the osseointegration diabetes due to the opening and risk of infection. 2 weeks ago, it's no more a contraindication. They excluded the diabetic from being as a contraindication at all, and any patient can do it. Yes, there are certain criteria for choosing the patients, but from 2019 to 2024, most of the criteria has changed a lot. Most of the excluded people before were already been involved and included for the criteria in the past few months. So definitely for the next few months, it will change again.
Of course.
And hopefully it will add a value and be a beneficiary for our MPT population.
Totally agree, and always be open for such interventions, like, I mean, advanced technology, and I agree with you in terms of the next, like, scientific like meetings. It has to be, in addition to, by the way, even the TMR as well. It's a very important topic to be discussed in such occasions. Thank you so much.
I would like to thank our panelists for the informative and enriching discussion, and I appreciate the outstanding contribution from the audience. Now we will stop for a prayer time and a coffee break. We will resume at 3:15.
إذا ممكن الكل يطلع على المسرح لصورة جماعية. فريق إيفاء، فريق إيفاء، صورة جماعية. مشوار ممكن بس تذكر الناس اللي في الممر.
في عالم مليء بالتحديات يصبح التأهيل المتخصص بوابة للأمل والتغيير. في عالم مليء بالتحديات يصبح التأهيل المتخصص بوابة للأمل والتغيير. في عالم مليء بالتحديات يصبح التأهيل المتخصص بوابة للأمل والتغيير. في عالم مليء بالتحديات يصبح التأهيل المتخصص بوابة للأمل والتغيير. في عالم مليء بالتحديات يصبح التأهيل المتخصص بوابة للأمل والتغيير. في عالم مليء بالتحديات، يصبح التأهيل المتخصص بوابة للأمل والتغيير. في عالم مليء بالتحديات، يصبح التأهيل المتخصص بوابة للأمل والتغيير. في عالم مليء بالتحديات، يصبح التأهيل المتخصص بوابة للأمل والتغيير. في عالم مليء بالتحديات، يصبح التأهيل المتخصص بوابة للأمل والتغيير. في عالم مليء بالتحديات، يصبح التأهيل المتخصص بوابة للأمل والتغيير. في عالم مليء بالتحديات، يصبح التأهيل المتخصص بوابة للأمل والتغيير. في عالم مليء بالتحديات، يصبح التأهيل المتخصص بوابة للأمل والتغيير. في عالم مليء بالتحديات، يصبح التأهيل المتخصص بوابة للأمل والتغيير. في عالم مليء بالتحديات، يصبح التأهيل المتخصص بوابة للأمل والتغيير. في عالم مليء بالتحديات، يصبح التأهيل المتخصص بوابة للأمل والتغيير. في عالم مليء بالتحديات، يصبح التأهيل المتخصص بوابة للأمل والتغيير. في عالم مليء بالتحديات، يصبح التأهيل المتخصص بوابة للأمل والتغيير. في عالم مليء بالتحديات يصبح التأهيل المتخصص بوابة للأمل والتغيير. في عالم مليء بالتحديات يصبح التأهيل المتخصص بوابة للأمل والتغيير. في عالم مليء بالتحديات يصبح التأهيل المتخصص بوابة للأمل والتغيير. في عالم مليء بالتحديات يصبح التأهيل المتخصص بوابة للأمل والتغيير. في عالم مليء بالتحديات يصبح التأهيل المتخصص بوابة للأمل والتغيير. في عالم مليء بالتحديات يصبح التأهيل المتخصص بوابة للأمل والتغيير. في عالم مليء بالتحديات يصبح التأهيل المتخصص بوابة للأمل والتغيير. في عالم مليء بالتحديات يصبح التأهيل المتخصص بوابة للأمل والتغيير. في عالم مليء بالتحديات يصبح التأهيل المتخصص بوابة للأمل والتغيير. في عالم مليء بالتحديات يصبح التأهيل المتخصص بوابة للأمل والتغيير.
Please join me in welcoming Dr. Amal Tannab.
Good afternoon, everyone. بعد الاحتفالات حسيت إن خلصنا. Anyways, we always talk about the bright side of prosthesis. Today, unfortunately, in my presentation, I will talk about the dark side. So my topic will be about long-term complications of residual limb, and not only residual limb actually, but overall long-term complications of using prosthesis and residual limb complications. This is my disclosure. So what are the secondary physical and medical conditions associated with lower limb amputation and the impact of long-term use of prosthesis at the level of musculoskeletal, skin, and nerves. Musculoskeletal pathologies develop as a secondary complications in people with amputation. An alteration of biomechanics occur with the use of one or more prostheses. Individuals with amputation tend to favor their intact limb and stress it more during mobility and daily activities. This patient, actually, she's a 37 years old female. She came to my clinic after 3 years of amputation. When she came, so in the background of fractured left femur, status post-fixation with plates and screws. When she came, she presented, unfortunately, with 40-degree flexion contracture in the left knee. She also reported chronic pain, bone pain in the residual side. As you can see, it's really obvious the difference in bone density between the residual side and the sound limb. You can see also osteoarthritic changes already developed in both sides. And you can notice as well, it's a very short residual limb in the X-ray. So osteoarthritis, this is one of the complications, and it's more prevalent in the sound side or sound limb or contralateral limb than the residual limb of people with amputation. If people with amputation don't learn to properly use their prosthesis or bear weight equally between both sides, they may further compromise the integrity of their intact limb. From here, it's very important person with amputation to have a very good gait training, prosthetic gait training. Another complication, osteopenia. Osteopenia is very common, it's more common in the residual side compared to the contralateral side due to decreased vertical loading, disuse atrophy, decreased muscle mass, lack of muscular contraction during activity, and immobilization of the residual limb in the socket. This will lead to osteopenia and osteoporosis, as well as lack of exercise may be associated with increased bone absorption. Transfemoral amputation have lower bone mass density in the residual femur than do people with transtibial amputation. We talked about contracture already. I just want to emphasize more on the risk factors, which include limited mobility, delayed wound healing, short residual limb, pain residual limb, and it's more likely to develop in older patients, particularly those with dementia and prior ipsilateral weakness due to stroke. And failure to provide adequate post-operative analgesia may also result in flexion contracture, as the patient يعني خلينا نقولها بالعربي يحب الكومفورت زون. He will flex his knee, he will put pillow under, and unfortunately ended up with flexion contracture. That's why I think education to the nursing is very important. I think already Dr. Hussein reported about the possible complication if we have more than 25 or 20 degree contracture, which can lead to compensatory lumbar lordosis, and this will lead to chronic back pain. Also, contractures decrease the effectiveness of the movement at the joint, which has impact for control of the prosthesis. For example, if this person develops a flexion contracture at the level of the hip, he will have difficulty to operate his knee unit. طبعاً, if significant contracture develops, it may not be possible even to be corrected with physical therapy. Possible options to manage contracture, physical therapy, dynasplint or progressive dynamic splinting. We can try serial casting, of course, pain management in all phases. And then as a last resort, surgical interventions like tendon lengthening, osteotomies. Unfortunately, not all patients are fit for surgery. Most of our patients are having different and many comorbidities. So they might end with to be non-prosthetic users. Because management is time lengthening and costly, we should work on prevention, as our colleagues said. This is just to emphasize the preventive measures, prone positioning for 30-minute daily, rigid removable dressing. صراحة يعني I read different studies about it. The Australian guidelines, they recommend it, and the US as well, but all recommendations based on weak studies. Zimmer splint, we used to use it, we used to do it in Canada, post-op, and on board. Case 2, 38 years old lady with history of peripheral neuropathy in 4 limbs, undetermined diagnosis, but actually she's a picture of Charcot-Marie tooth. Complicated with right transtibial amputation at the age of 21. Other foot showed Charcot changes. She presented complaining of lateral knee pain. This is her X-ray. As you can see, a bony spur over here. Bony spurs may develop over time. If painful, they are often palpable. If they cannot be accommodated in the prosthetic socket, surgical resection is indicated. Third case, he's a 43 years old male with a history of bilateral transfemoral amputation related to compartment syndrome. History of illicit drug use, presented with severe pain in right medial residual limb and sudden increase in his phantom pain. Patient was progressing very well with rehab team as he was on a training on using bilateral stubbies. Unfortunately, almost like 3 days prior to discharge, he developed. Actually, he was complaining of phantom pain, which was well controlled with medication. And then suddenly, in the right side, he cannot bear his stubby, and it was very painful. The phantom pain was significantly increasing. So pain treatment was modified with no good results, unfortunately. On examination, there is tender to touch at the distal medial femur. صراحة our first differential was neuroma at that time. We did ultrasound, which showed neuroma in a different place, which was not painful. So the X-ray, as you can see over here, it's not clear صراحة, but if you can identify the pathology over here, popcorn-like appearance, fluffy, which indicate HO. Heterotopic ossification. Already Dr. Hussein, he pointed at this complication as well. HO has been reported at the end of residual limbs, usually traumatic etiology of amputation. We usually treat with prosthetic modification, and we rarely need surgical excision. For this patient, actually, we referred him to ortho. He was in significant pain. Functionally, he was doing very well, and suddenly he was regressing back. I'm not sure. In my reading, I didn't find any recommendations in amputation regarding using endomethacin or radiation therapy. I know radiation therapy, there is evidence in post-hip arthroplasty. I didn't find any studies. Maybe Dr. Faiz, you can share some of later on. Case 4. So this is a 48 years old male with history of right transfemoral amputation, presented with non-tender fluid-filled sac, as you can see over here. So this is a bursa over the distal posterior femur, occur from repeated friction and pressure. Can be resolved with modification of the socket or refabrication to decrease mechanical stress. If bursitis develop, we should manage accordingly. If there is infection, we need to aspirate, test the fluid, and give antibiotic. Maybe if it's not, they can benefit from steroid or bursectomy if it is recurrent. Case 5, this is a 35 years old male with history of primary Raynaud's, status post-right transfemoral amputation related to infection of his foot, which was injured with a screw, resulting in necrotizing fasciitis. He reported history of delayed wound healing due to infection. He received wound care and antibiotics. He presented to my clinic after 6 months from his amputation to assess for prosthesis use. Functionally and physically, he did very well. He received rehab prior to his visit. So this is his X-ray, if you can identify the findings. Before the X-ray, his exam was positive. There is discharge, serous in nature, tenderness at lateral anterior distal end, but there was normal temperature and no redness. You can see in the X-ray of the residual limb, there is features of periostitis, there is some edema surrounding soft tissue edema, MRI of the lower extremity with contrast confirmed chronic osteomyelitis. His ESR was 13, so I referred this patient to orthopedic for further management. Just to summarize the MSK complications, we talked about bursitis, osteopenia, osteoporosis, contracture, mostly on the residual side, osteoarthritis, more prevalent in the sound side. Very important thing is I didn't mention earlier, which is deconditioning. 4% to 5% of muscle mass will be lost weekly if the patient on bed and not moving, and even higher if the patient is older with many comorbidities. Leg length discrepancy, this is very important. Complication due to imbalance in the size between the prosthetic side and the sound limb. And actually it can result in many different gait deviation and ended up with chronic back pain. تمنيت ان البروستاتيست موجودين مين فيه؟ Only you. This is very important to, this lecture is very important to prosthetist صراحة and physio and us as a physician. Neuroma, تمنيت عبد الله موجود because I'm gonna mention a point he asked about. Only 10 to 15% of neuromas will cause pain. If the nerve is resected after a traction has been applied, it will usually retract into the soft tissue and not be symptomatic, as Dr. Hussein mentioned. Diagnosis by palpation of a firm nodule, which results in a tingling discomfort in a peripheral nerve pattern, most likely due to neuroma. Diagnostic ultrasound, to me it's superior to MRI, as you can with probe press and know which neuroma to be injected. Not all neuromas need management. So briefly, management should begin with socket modification. Injection of the neuroma with lidocaine and corticosteroid may provide symptomatic relief. Focused ultrasound ablation, which can be performed by IR, interventional radiology, and if pain continues, surgical treatment will be required. New approach to surgical neuroma treatment, which is the TMR, targeted muscle reinnervation, or RPNI, regenerative peripheral nerve interface. So published results demonstrate that you don't get neuroma recurrence, residual limb pain decreases, and phantom limb pain decreases. No studies yet on nerves with underlying pathology like diabetic neuropathy being done as a treatment of neuroma, but as well as prevention. This is really a new approach. It can be done even at the time of amputation. وهي بدأت أساساً فكرة TMR and RPNI as a research between a physiatrist and a plastic surgeon to improve the neurointegration of the prosthesis. And they found a positive impact على neuropathic, على neuroma pain and the phantom pain. The difference between both, RPNI is the placement of a free nerve ends into free devascularized muscle or dermal graft. TMR include excision of the terminal neuroma, and then the fresh end of the nerve is coapted to a nearby expandable motor nerve. I have a nice video here just to show you how TMR...
The nerves in your body are like power lines. When a power line breaks in a storm, the live wire sparks because the energy has no place to go. Those sparks are like the pain you may feel after an amputation when your body's power lines get broken. There may be pain because the energy in the nerve is looking for somewhere to go and something to do. When a nerve is broken during amputation, it keeps growing to try to make a connection. If it doesn't find a connection, it can grow into a painful jumble called a neuroma. Or it may think it's still connected and fool the brain with confused signals from the missing limb, causing phantom pain. If you think about the live wire from the power line, the only way to stop the sparking is to reconnect the wire. TMR, or targeted muscle reinnervation, is a surgical procedure that reconnects painful nerves that have been broken by an amputation. In TMR, a surgeon fixes the power line by reattaching the broken nerve to a nearby nerve and the muscle it activates. This gives the nerve a purpose, with somewhere to go and something to do. A purposeful nerve is a happy nerve and one less likely to cause pain. Happy nerves mean a happier you. Learn more about TMR and whether it may be an option for amputation nerve pain relief. Visit TMR Nerve. The nerves in your body are...
يعني باختصار اعطوا هالنيرف شغلة ولا بتقعد تول bug the patient. The RPNI effectively and actively guide axonal regeneration into denervated targets. As I said, positive impact on neuroma pain, phantom limb pain, prosthetic experience, and psychosocial well-being. And this is just to show you the steps of doing the procedure. Again, more studies about the TMR. This is a randomized controlled trial stated that TMR improved PLP and trended toward improved residual limb pain compared with conventional neurotomy. The study was in August 2019. Also, it's reported in the Journal of Plastic and Reconstructive Surgery about the effectiveness of targeted muscle reinnervation in reducing pain and improving quality of life following limb amputation. This is a systematic review. So they highlighted the TMR capacity to significantly reduce both residual and PLP and reduce opioid dependency, increases ambulation rates, as well as enhance the use of prosthetic device. This study in International Open Access Journal of American Society of Plastic Surgeons, again, here they are talking about the RPNI, treat and prevent traumatic nerve pain. Moreover, it's a powerful tool for enabling the use of advanced neuroprosthetics and more recently sensory feedback. I saw 2 patients who did the surgery and there's significant improvement in the pain after the surgery. We will move to the last part, which is the skin complications. 35 to 50% of lower limb amputees experience skin complications. Skin complications are a result of mechanical stress, shear forces, friction and excessive loading pressures, humidity, sweating, and stretching of the skin. Ulceration. Most common skin complication, around 27%, caused by mechanical injury, usually pressure over bony prominence, resulting in tissue destruction. Insufficient socks resulting in end bearing can also be a result of friction from a loose socket as well. We always recommend the patient to have a new socket once he requires more than 10 plies of socks. Grafted skin are more prone to ulceration on residual limb. Management: decreased or complete cessation of prosthetics use until ulceration is healed. طبعا this option, unfortunately, our patients, they hate this option. Appropriate wound care to facilitate healing, socket modifications, and education on sock and liner management. My 6th case for today, this is a pleasant 53 years old lady with transtibial amputation, presented with a new blister on her anterior lateral incisional line. I'm not sure if it is clear, but this is the one. It was aspirated. I whipped it with Providine and added Caltostat and Tegaderm just to help absorb the fluid. We recommended her to decrease her prosthetic use to reduce irritation in the area. Prosthetic evaluation, we recommended her to seek medical attention if developed signs of cellulitis, and I monitored her progress. She did very well. Another skin complication, which is epidermoid inclusion cyst, occurs when follicular keratin plugs develop and become embedded in the skin from repeated pressure and friction from the prosthesis. Most common along the brim of the prosthesis, can be asymptomatic or drain intermittently to become infected and painful. Management: briefly, good skin hygiene, provide as much pressure relief as possible in prosthesis. If infected and painful, incision and drainage with antibiotics. If a chronic, we can refer to dermatology for surgical excision. Hyperhidrosis, excessive sweating, can be very uncomfortable for the patient and is experienced by around 30 to 60% of amputees. The wetness in the socket can contribute to skin irritation and maybe candida infection. May also interfere with suspension of the prosthesis. Management, we can try topical antiperspirant. The over-the-counter ones, the patient can use it anytime he wants, or the prescribed ones, like Drysol. We recommend change socks, TID, wash the socks, air out the liner and socks at bedtime. Intradermal botulinum toxin can be tried to manage sweating. If infection present, we can treat with antifungal. Contact dermatitis may be related to contact with any of the components of the prosthesis. Creams applied to the residual limb may also be a source of irritation. Dry, sensitive skin seems to be especially prone to contact dermatitis. Management, again, avoid irritant as possible, apply moisturizer at bedtime, may benefit from topical corticosteroid, especially if it is acute. Also, some gel liners cause mild irritation to skin that can be stopped by use a nylon sheath or a silver sheath, or maybe cutting the liner, the top of the liner in a wave pattern, or using hypoallergenic types of liners like urethane liner. Allergic dermatitis may develop delayed hypersensitivity to components of the prosthesis and to moisturizers being applied to the skin. Usually complain of intensive itching, burning of the skin inside the prosthesis. We should treat acute episode with cool compresses, anti-itch lotion, and cortisone cream. I think this is the last case. He's a 44-year-old male with a history of left transtibial amputation since 20 years, traumatic post-motor vehicle accident. History of left femur fracture, it was in April 2024, managed with casting. Once he was allowed for total weight bearing and back to prosthetic ambulation, he reported pain in his knee only when he put pressure and walked with his transtibial prosthesis. His prosthesis is tight due to edema after fracture. He reported no total contact with distal residual limb. He reported fitting concerns actually years back. His last prosthesis was 10 years back. This is his residual limb. So this is a case of choking syndrome or a distal venous congestion. Usually it starts with milder pictures, and in this case it can be manageable. Unfortunately, if he came at late time, we need a dermatology opinion as there is a risk of transformation to squamous cell carcinoma. So edema accumulates in the distal residual limb if the limb is constricted proximally or if the distal end of the residual limb is not supported. After an extended period, the patient may develop verrucous hyperplasia. The skin can take on a warty appearance, as we can see in the previous picture and this picture, and may become ulcerated. Causes: post-op edema, elastic bandage applied inappropriately, weight gain, increase in residual limb size, no longer fits into socket, but the patient continues to wear prosthesis, so loss of distal contact. Rapid shrinkage in residual limb and additional sock result in socket being tight proximally and loss of contact distally. Management option can be socket modification to provide distal contact in the prosthesis and ensure no proximal constriction. Residual limb compression to control edema and treat secondary infection. In summary, persistent pain may be a sign of residual limb ischemia, neuroma formation infection, or a manifestation of a phantom limb syndrome. So we need to do our differential once the patient came to us complaining of residual limb pain. And we can be systematic from outside to inside, like any skin causes, any soft tissue causes, muscles, bone, joint. Pressure points that develop over bone spurs or pathologic bone formation can also be a source of localized pain and can be identified with X-ray. We can use our resources as well. Again, infection like osteomyelitis can also be a source of chronic post-operative pain. We need to put this in our mind. Take-home message: knowledge of the possible secondary complication of amputation and long-term complications from prosthesis use can help rehabilitation practitioners provide high-quality prophylactic care for their patients with lower limb amputation. Again, educating the person about residual limb care, including daily cleaning of the residual limb with soap and water, dry it, compression to minimize swelling, regularly inspecting the residual limb if there is any irritation or skin breakdown and erythema. So again, education is very important. very important to prevent complication. مهم جدا نحن يعني نزيد الوعي عند المرضى ببروشور educate them about possible complication, how to prevent it at early stage. Thank you very much.
Thank you very much, Dr. Amal Tannab, for the valuable participation. And finally, I would like to introduce our last presenter for today, who will discuss with us about the review, the evidence-based practice in physical activity for people with lower limb amputation. She is a senior physiotherapy specialist. Please give a warm welcome to our final presenter, Ms. Shorouk Maqbool.
Hello. Yeah, okay. So I am the last one. Thank you for your staying. It's literally a pleasure being a part of this big event. Okay. Here I am going to review the evidence-based practice in physiotherapy activity for people with lower limb amputation in the long-term phase. So the long-term phase starts immediately after discharge, as we know. Effective discharge planning is ensure continued use of the prosthesis once the patient have reached their goal or reach a plateau. I will gonna start with the guideline that's provided from the British Association of Chartered Physiotherapy, which was updated as a 3rd edition in 2020. Actually, there is no evidence found in the literature to support how the patient will gonna be discharged from physiotherapy and rehabilitation services. However, it's really recommended that patients keep having a regular visit, especially with the first 12 months after discharge, which can be highlighted the potential for the prosthesis non-use. And also another group suggests that we have to use recognition modeling, which is increasing the balance, confidence, ability to pick up object from the floor, turning to look behind, and also placing alternative foot in a step, which can make sure that the patient will gonna have successful outcome using the prosthesis during the mobility. And here I will gonna mention secondary musculoskeletal and degenerative change patients with the traumatic amputees could face. These population will gonna be at risk of developing knee OA, so we have to make sure that strengthening the asymmetry, and also we need to do a full gait assessment to make sure if this patient need further rehabilitation or physical therapy investigation. And chronic low back pain, it's a significant problem, especially in the first 2 years post-amputation, but this problem is not common in the vascular amputee population. People with amputation have a greater restriction in community activity, and it shows that linking increased physical activity to enhance the community participation and improve the prosthesis use. Using outcome measure can be helpful in measuring and monitoring the community integration for this population. For example, TABE score, which was used by Baker, who identified the association between ambulation, mood, community integration, and the quality of life. In 2018, the Chartered Society of Physiotherapy ran a campaign, Love Activity, Hate Exercise, which highlighted the problem of physical inactivity. And in the following year, 2019, they published a guideline which highlighted the health benefit of increasing the physical activity and participation. The guideline recommends 150 minutes of moderate intensity activity, for example, brisk walking, cycling, or 75 minutes of high intensity activity such as running, or a shorter duration of very high intensity activity such as running or stair climbing, or a combination of all of them. So combination of from moderate, high and very high intensity activity. Regarding the muscle strength, adults need to develop or maintain the strength in the major muscle group at least 2 days per week, and by doing resistance exercise, carrying heavy shopping bags, or heavy gardening. And as we know, any activity is better than none. About the effective of exercise in amputee, a 12 weeks exercise program at 1 year follow-up will gonna reduce risk of fall, increase the walking speed. Evidence link amputees who have better fitting and stronger will gonna impact their high functional capacity and better gait. And also brisk walking, for example, will be enough to increase amputee energy about 3 metabolic equivalent. So patients with lower limb amputation need to be educated about the importance of having physical activity and engaging with community. And also we have to aware them about the most common problem they might face with using the orthotic. For example, low back pain or knee OA, such as I described before. And also open access should be available for them, because they might face any circumstance change in their society, physical level, or returning to work. So we have to provide them full support and to make sure they are continuous use of the prosthesis. Here I will mention briefly exercise in person with unilateral lower limb amputation and contralateral limb amputation. A study was published in 2019. This study investigates the exercise habit of individuals with unilateral non-vascular lower limb amputation, the traumatic population, highlighting the maintained balance between physical and minimizing the risk of injury critical for patients with amputation, because these population have risk of weight gain, which can be regarding to the physical inactivity. And also they might face gait abnormality as that will be increasing the load in the sound limb with using the prosthesis as a long term. The conclusion was engaging an exercise routine greater than moderate intensity will be significantly increase the risk of intact limb injury. And here there is a scoping review to measure if the patient with lower limb amputation having at least the 10,000 steps per day. The purpose of this scoping was to map the evidence regarding steps per day as a physical activity measure for this population. People with lower limb amputation take fewer steps per day than the recommendation. So for suggested for greater and general health for them, we have to educate the patient about the benefit of increasing the steps per day, which can be impact healthy on their general health, and it will be useful goal for this population. Effective of guidelines as an evidence-based amputee rehabilitation program. So a small percentage of people with lower limb amputation who actually receive physiotherapy and rehabilitation services. Majority of them, they are not receiving these programs. So we have to determine whether the evidence-based amputation rehabilitation program would be improving the functional mobility for people with unilateral transtibial amputation who already complete their physical therapy program and the prosthetic training. So population with lower limb amputation who receive the evidence-based program rehabilitation program have significant improvements in their functional ability. This program contains from 5 elements: cardiopulmonary, which can increase the flexibility and endurance, trunk and lower limb strengthening exercise, weight bearing and distance control, prosthetic gait training, balance and coordination. This study was done to answer the question, answering 2 questions. Do the physio How can I go back again? Okay. Yes. Okay, so this study was to answer this following question. Do physical activity, exercise, improving fitness, mobility, and functional capacity in this population? And what is the minimum dose, frequency, intensity, and the duration? Sorry. Yes, there is a technical issue here. So there was a study was done to answering these following questions. So the recommendation was at least 1 to 3 frequency exercise per week, and for the duration was 20 to 60 minutes. And it's also recommended to have a combination between aerobic, balance exercise and strengthening, which can impact this population to increase their balance, speed, functional activity. Okay. So all the evidence was supportive physiotherapy, which can be significantly and meaningful impact the patient with lower limb amputation. Okay, thank you.
Thank you, Ms. Shurug, for the great insight and valuable explanation for this topic. And now I would like to invite you guys back to the stage, and so we can start our panel discussion. Okay, since this is the last panel of discussion we have today, so I would encourage you to make the most valuable opportunity to ask our panelists here so many questions as you can, and we are open to for the questions that you have. Any question from the audience? Okay, I will. Oh, there is a question.
My question is, as like a healthcare provider, I'm a physiatrist in KFSHD. So let's say we face a patient with lower limb amputation or like amputation. What's the next step? Is there like for example, a pathway that we can refer the patient to? What can we tell the patient? What to expect? Like, is the prosthesis covered? Is the PT covered? Is rehabilitation covered? Like, what can we do to make that journey smoother? And I've heard, like, from yesterday that we would probably have some issues with the insurance in the future or the coverage in terms of the prosthesis. So what can we do to like make that transition smoother for the patient, or help them access like support either from charities or governmental? I know, like, for example, for the equipment, they can apply through التأهيل الشامل. I'm not sure if there is a process for the prosthesis similar to that or not. Thank you.
Thank you for your question. Yes, there is a pathway, and between the departments in King Fahd Specialist Hospital and Dhamma Medical Complex, especially, I'm talking about a governmental level, of course. We are the only center providing prosthesis to our public community, governmental, I'm talking about the governmental hospitals. So what we usually do is the surgeon usually refer the patient to us through a medical report, and then I receive the patient in my amputee multidisciplinary care clinic. And then we do all what we're talking about, the multidisciplinary team, assessment for prosthetic eligibility, and we decide which prosthesis he will take with me and my team, the physiotherapist, prosthetist, occupational therapist, and we provide the care to the patients if they need, like, for example, if he was discharged and he still need rehabilitation, we provide him with the rehabilitation as well, even if he is from King Fahd Specialist Hospital. Second question regarding the على المستقبل وش ممكن يصير على التأمين. So for now nothing is changing. التأمين الصحي راح يكون موجود وراح يدفع إلى المريض، لكن ما أدري دكتور فايز عندك فكرة عن الأمور هذه مع الصحة القابضة؟ I have no idea صراحة. What I know إنه there will be no changes at the level of the patient، وممكن بالعكس الأمور تصير أفضل يعني. Yeah. So no worries. Prosthesis is paid by the government.
It should be covered for the patient.
Yes. بس طبعا احنا we are limited عشان نكون واقعيين. We as a governmental secondary care hospital, we provide limited types of prosthesis. Sometimes patients will need more advanced prosthesis طبعا, and this will take another journey.
Any other questions? Okay, I will ask the first question for Ms. Shuruk Maqbool. As we know that there are various outcome measures for lower limb amputation. In your opinion, what are the most commonly used outcome measures in research and clinical practice, and how reliable are they?
As I mentioned in my presentation, TAPES score was one of the most common used because we have to identify how is the patient is integrated with the society, how is the mood affecting this patient, because as we mentioned from yesterday, patients need to have full support from psychiatric, their family, to provide this to cover this maximum need, and also to help them to reach their physical activity before amputation. Actually, there is still some limitation because there is not enough studies was done. We still this area needs to develop more. In our hospital, Dr. Amal, are you following using outcome measure? And did you usually, I attend one session, usually compare the patient, the initial evaluation with the second visit, and keeping continuous evaluation for this patient to make sure first if the patient is fit for using orthotic and how can it be trained them in the future.
In my experience as newly establishing amputee multidisciplinary rehabilitation program, we are working to improve our program, introducing outcome measures to our team, our physiotherapist, our like for example L-test, a 2-minute walk test, socket comfort score, confidence, and all of these important outcome measures. There is area of improvement, alhamdulillah. Me and my team, we are working.
And just a follow-up question also for, regarding the outcome measures. If you have a patient with either a vision impairment or cognitive defect, in what case now you will, like, how would you change the way you take the outcome measures? Is there an outcome measures that you can use with these type of conditions?
Very interesting question, thank you. From my experience, لقيت إنه في اختلافات, especially on vision and cognition. Some of the consultants, they are more confident to give a prosthesis, especially if this person, he have a good caregiver all time, and he feels he will be safe to use it. طبعا with a limited use, like maybe K1, at least K1 level, or K2 if it is only vision problem. But he will need, of course, close supervision and someone with him. But some patients, if they are, for example, living alone and they don't have any support with significant visual impairment, this will change my opinion regarding providing the prosthesis, because we will put him, he will be at a risk of fall, high risk of fall actually. Again, cognition is very important. Actually, one patient was referred to me. He was in acute psychosis. So I didn't provide him with a prosthesis, and I requested re-evaluation by a psychiatrist. If he is well controlled on medication, I don't see a strong contraindication to provide him with a prosthesis.
Okay, and another question for Dr. Amal. I would like to ask you if there is a case where patient with a AK amputation above knee has a dislocated hip in the amputated side. What is the treatment approach for this case?
In my practice, I didn't see any patients with dislocated hip.
I'm not sure, Dr. Faiz or Dr. Maha, did you, in your practice, did you find any?
Definitely, if there is a musculoskeletal complications, has to be addressed before you proceed with the prosthetic intervention. So, if there is an issue with regard to stability, to the risk that this musculoskeletal put on the patient ability to walk, definitely we urge to fix that problem first, and then we work on exactly with orthopedic surgery evaluation, and then after that we can proceed with the appropriate intervention. This is if you are referring to having the problem with the hip at the amputated side. Okay, yeah, but if it's the contralateral side, it's, not a contraindication. It's definitely an advantage to initiate the prosthetic intervention early, so the patient, he can start to load on the normal side, on the amputated side, since there is no issues with the hip joint over that area.
I think this is also maybe more common if the person is already having significant contracture in the hip. They are higher risk to have dislocation, and if they have a significant contracture, then maybe they are not even a prosthetic users.
Another case that I want to ask about, if there is a patient with a BK level below knee and has an ulceration in the patella tendon. In this case, and also he is a diabetic. Diabetic, yes. Yeah. What is the treatment approach for this patient? What is the treatment plan? Is it possible to, if the patient cannot discontinue wearing the prosthesis because of work matters, how are you gonna deal with this condition?
Excellent question. Since the ulcer is in the weight-bearing area, unfortunately we will ask to discontinue the prosthesis. Another option, a prosthesis is one type of ambulation. We have other things to use to ambulate, like a wheelchair. So wheelchair is another thing can be used by the patient to ambulate and go to his or her work. So, and then of course we will work on wound management.
This is actually a true case I've faced when I was doing my placement in the UK.
I don't recommend Dr. Mohammed the walker لأنه we don't know for how long this ulcer will heal, and then jumping in one side will put the patient at risk for complications in his knee pain, sound side knee pain, hip and ankle. So for me, I prefer the wheelchair. And also,
we have to assess his wound first. If the wound is very deep, yes, effectively, I prefer the wheelchair. But if it's manageable, it's better to put him on walker during a certain time. I think the wound will heal, and he will resume without any complication, because the problem with wheelchair, he can develop a contracture, flexion contracture of the knee.
We can add board.
Yeah,
board, yes.
Sure.
Yeah.
We have to give some recommendations to the patient, but I think we prepare him with a walker if it is manageable. I'm not talking about the deep wound, which is really, which needs months, sometimes years to heal. This is my.
I got your point. Yeah. I think it can be approached in a different ways. This is my way to approach this problem. Since it's a weight-bearing area, I'm afraid to make the wound even worse. And again, if it is a short distance period, he can use the walker for transfer. But I will not recommend long distance walking with the walker.
I think what he was mentioned,
that we have to just motivate the patient to maintain any activity, because if the patient being inactive, we're gonna the patient will gonna have more complication, weight gain, and then the patient will gonna be relay in wheelchair. Then after he gets healed from the diabetic side, then he will gonna be facing another problem. How to gonna he return to the physical activity, and who knows?
If it is a superficial ulcer,
It
he
might
will
be
not
managed.
take time
Yeah,
to heal.
but unfortunately, if it's gonna deep ulcer, it's gonna be complicated.
And this is actually an actual case I've encountered when I did my placement. The patient is a chef, and so it's impossible to put the patient in a wheelchair or in a walker. So we faced challenges to have this patient walk with the prosthesis, and he cannot even take an annual leave from the work. And so what we did, that we added pads on the medial and lateral wall, also in the popliteal area, to add the pressure on different area from the patellar tendon. But what we did also, we actually heated up the area of the patellar tendon to release the pressure. It is not, because the patellar tendon is actually very important in the weight bearing, but we had to do that because the patient eager to wear the prosthesis. He don't want to leave the work or even discontinue using the prosthesis.
Well, modification should be done as soon as possible. I agree with you.
Assalamu alaikum. Sorry to disturb you, doctor. I am Digambar, a certified prosthetist orthotist working with Dr. Amal. As you said, this case, it is a special case and his patient is safe. So we can go for a total contact socket. If the option is available in the center, immediately should go for a total contact socket. Patellar tendon, leave it the patellar tendon. Trim line should be little up. You can take it whole patella also. Like we are PTB and PS, we are doing in short storm, you can do that. Another thing, like harmony socket, if it will go for harmony socket also, it will be very effective. But it should be temporary. When the wound area will heal, then immediately total contact socket with patellar tendon pressure little bit, it will be very helpful. Instead of giving padding on supracondylar area, popliteal area, it is not going to helpful. Because if you will give a popliteal area padding, it will give a force, anterior directed force towards the patella, so patellar tendon. So definitely there will be pressure on patellar tendon. So leave the patellar tendon area and cover the trim line and cover the patella also. And it should be perfectly total contact socket like a harmony or one-way valve. It will be helpful for sure, but subtle. When there will be wound heal, again you have to come back with total contact and patellar tendon bearing. Thank you.
Thank you very much for.
I'm not sure if it is, to give another socket.
It is kind of like impossible to give another socket.
For a temporary problem.
Yeah, for a temporary, but also if we consider that the patient doesn't want to take more time with another socket and to wait until the delivery of the new socket. Another thing that, as I mentioned, that the patient said he cannot leave the work. He wants something like urgent or immediate changes that we can do in the clinic.
Well,
another thing, maybe we can also, in this case, as you know, person with amputation or amputated or limb loss,
راح تجيهم أيام they will not use the prosthesis for a reason or another. I think involving vocational therapy, occupational therapy to address environment of the work is very important. It should be once he had the amputation, OT can assess the work environment, do their modifications, give suggestions, and the work should make it comfortable for the employees with amputation.
My way of approaching this case would be going with the preparatory prosthesis. He will be able to use it just for a certain period of time. I will remodify the socket without loading the patella tendon, and then if the wound is superficial, and then when the wound is completely healed, he can go back to his previous prosthesis.
This is also another solution. Yeah. Any other questions? I would like to ask a question for both of you. What if you encounter a challenging condition where a patient has a stroke on the same side that is going to be amputated? And how is the approach of the from the multidisciplinary team, like the physiotherapy and you as a consultant, and how are you going to approach this case?
So he already has.
He has a stroke
And amputation.
and
both.
will be amputated.
Will be which level? In the amputation in the weak side.
And the weak
right?
side, yeah.
Our approach will
Depend
gonna
on
be,
primo, yeah?
yeah, depending on the motor and depending on the patient. So we need to do a full examination to determine how is the patient muscle strength, the motoring, how is the lesion based on the neuroscience. So after the finding, we're gonna figure out if the patient is eligible to have a prosthetic or not.
I think I will first I will approach his neurological injury first and assess him from A to Z, like if he's having any cognitive impact, because we know stroke can affect cognition, can affect vision, can affect muscle power, as Ms. Shuruq mentioned.
Not
sensation,
the upper limb as well.
Upper limb as well. Sensation, right? Spasticity, bowel and bladder problem, which is another important thing. So not all stroke patients, I think we cannot approach, there is no guideline to approach all stroke patients the same. So it's based on the case, I think.
Any questions? Okay. I think we will wrap up the discussion and we will take a 15-minute break. And here we go. Mr. Dari just arrived. We would like to wrap up this conversation, and then we will move on to the final speech. Thank you very much for your contribution. Also, thank you the audience who asked a question. في هذه الدقائق نستمع إلى رئيسة اللجنة العلمية في الملتقى الدكتورة أمل طناب حول أبرز المخرجات والتوصيات الخاصة بالملتقى. الكلمة لك دكتورة.
Thank you very much. My first part would be English, and then I will switch to Arabic. I extended my heartfelt thanks to each participant, guest, and speaker. Your presence and insightful contributions have been the pillars of this event success. Your passion and expertise have not only enriched our discussions, but also inspired us all. I cannot proceed without expressing my deepest appreciation to the organizers and volunteers. So thank you very much. أستاذة رنا مثل ما قلت لش أمس أبدعتي. طبعا بالنسبة للتوصيات ناقشت فيها الزملاء تمام. The most important thing from this symposium is to build recommendations, help to improve this field, and to يعني نحن ننقل المجال هذا نقلة نوعية. فإحنا نحتاج إن إحنا نعمل خلينا نقول ممكن مثلا to start association together بيننا إحنا كطاقم تأهيل بين الجراحين سواء الGS البلاستيك surgeons الفاسكولار surgeons وأي أحد involved المنتال health جدا مهمين social workers جدا مهمين فنعمل رابطة تأخذ المجال هذا إلى مستوى آخر. كذلك مثل ما قلنا أمس واليوم نوصي باستحداث سجل وطني لمبتوري الأطراف كحجر أساس لتحقيق معرفة الإحصائيات الدقيقة لأعداد وأسباب بتر الأطراف لدعم كافة البرامج الوطنية الوقائية والعلاجية والتأهيلية. كذلك I have a few recommendations over here. توحيد المعايير أو الناشونال جايدلاينز في تأهيل مبتوري الأطراف. تعزيز الكفاءات والفعالية في برامج التأهيل ممكن الريسيرش ممكن الإديوكيشن المؤتمرات هذه تكون بشكل دوري. دعم استخدام أحدث التقنيات والممارسات المبنية على الإيفيدنس بيست على جميع الأصعدة وجميع التخصصات في التأهيل. أستاذة رنا تحب تضيفي توصية من طرفك؟ أوكي تمام.
يعطيك العافية. فكرة عندي ليش ما يكون فيه منصة علمية للأمبيوتيشن أو مثلا زي مثلا Orthotics and Prosthetic Journal in the United States. Why we don't apply the same thing here in Saudi Arabia بس إنها تكون مثلا في خلونا نقول في الأمبيوتيشن ما يتعلق مجال التأهيل مجال الأطراف الصناعية برضو هذه فكرة أحس إنها كويسة.
هل تقصد educational إلى المريض أو على مستوى clinicians؟
just journals يكون فيه اللي هو مثلا موضوع الارتكلز يعني كل شيء متطور كل شيء حديث as a journal يكون موجود في المنصة هذه.
I agree with you. I totally agree. أستاذ ضاري تحب تضيف شيء؟
أول شيء أحب أشكر الجميع على وجودهم هنا يعني كل إنسان موجود جاء ضاف إضافة مرة جميلة جدا للملتقى هذا. تأخرت عليكم ربع ساعة لأن كان عندنا اجتماع مع ال ISPO International Association of Prosthetics and Orthotics العالمية. فكرتها إنه الاجتماع كان مخلص إنه قاعد نشتغل على إن نسوي مؤتمر آسيوي يكون هنا في السعودية في الأطراف الصناعية والجبال على مستوى
بيكون في السويد صح الجاي
في السويد. فإنه الشيء هذا لما نشتغل على طريقة انترناشونال على أننا نجيب العالم كلهم لنا لين هنا ونشتغل بالشغلة هذه بطريقة مرة حلوة شيء مرة جميل. فأبد وكفرد من عائلة إيفاء مجمع الأمير سلطان أبد كل الخدمة كل الدعم من ناحية تكنيكال من ناحية شيء نكون فيها نشتغل وياكم فيها عشان نثري للمجتمع الشيء هذا. بالنهاية آخرتها احنا ننبثق من المجتمع وإلى المجتمع. اعتبروا هذا بيتكم، وأنا أخوكم الصغير ومديرتي أنا تدعمنا الليدر دائما. فبالعكس خلينا نسوي شيء له أثر مرة جميل، وبالعكس منصة مفتوحة، هي ما هي توصية لليوم هذا، التوصية على مدى بعيد عشان نحط الأشياء على جانب تنفيذي على أرض الواقع. وأبد راح تكون في أكثر من اجتماع، أو أن نكون عندنا الكوميتي العلمية هذه ما تنحصر على أنه يعني one show yearly. إذا في كان كوميتي نتجمع عشان أن احنا نعزز البراكتس بطريقة أو بطريقة أخرى على اللون، بالعكس شيء مرة. شكرا.
الله يعطيك العافية.
شكرا جزيلا دكتورة أمل. والآن نستمع الكلمة الختامية لهذا الملتقى مع الرئيسة التنفيذية لمجمع الأمير سلطان للتأهيل إيفاء، الأستاذة رنا طيبة.
بسم الله الرحمن الرحيم. لمدة يومين متتالية 14 جلسة علمية و5 ورش متخصصة، ساعات معتمدة من الهيئة السعودية للتخصصات الصحية، معرض مصاحب، 5 جهات مشاركة، 10 رعاة. هذه أبرز ملامح الملتقى العلمي للتعافي وإعادة التأهيل لمبتوري الأطراف، والذي تمت إقامته بالشراكة بين مجمع الأمير سلطان للتأهيل إيفاء الطبي ومجمع الدمام الطبي. سعدنا بكم في أروقة هذا المجمع، ونثمن جهود الأطباء والأخصائيين في تقديم المحاضرات العلمية وورش العمل، والتي كانت إثراء علميا قيما. ونوصي بتشكيل لجنة علمية ذات أعمال مستمرة تنبثق من المجمع بهدف إثراء قطاع إعادة التأهيل من خلال اللقاءات العلمية وأوراق العمل وتفعيل التبادل المعرفي، وأن يتم جمع كل ما تم تقديمه في هذا الملتقى من محاضرات علمية في كتيب علمي جاهز للنشر بعد إذن اللجنة العلمية، بهدف الاستفادة والإفادة من قبل المتخصصين في هذا المجال. وسنظل نواصل العمل في مجمع الأمير سلطان للتأهيل إيفاء للاستمرار في عقد الشراكات مع الجهات ذات العلاقة لإقامة الملتقيات والفعاليات النوعية التي تساهم في تطوير منظومة الخدمات والإجراءات في مجال إعادة التأهيل في مملكتنا الحبيبة، حيث يضم المجمع 4 مراكز متخصصة: إيفاء الطبي في هذا المجال. شكرا للأطباء والدكاترة الأخصائيين والمشاركين وللحضور على هذا الإثراء المعرفي اللي تقدم هذه اليومين. وشكرا أيضا لرعاة الملتقى، بالتأكيد مجلس الإدارة اللي حريص كان بكل التفاصيل على إقامة هذا الحدث العلمي. وشكرا للحضور الكريم، ونسأل الله أن يعلمنا ما ينفعنا وأن ينفعنا بما علمنا، ونلقاكم بإذن الله في ملتقيات علمية قادمة. والسلام عليكم ورحمة الله وبركاته. شكرا.